We have discussed the location where they're secreted. We have discussed the mechanism of action. We have discussed how they are regulated in the body. Okay, what changes causing them to increase in release, what changes will inhibit their release. Okay, and some specific notes, just like we have discussed about the VIPoma, in which you get this secretory type of diarrhea, hypokalemia, and dichlorhydra, right? For the nitric oxide, we have discussed about the achalasia and the treatment of the achalasia. For the morphine, we have discussed about the erythromycin, how they stimulate them and can be useful for the treatment of diabetic gastroparesis. For the GLP, GIP, we have discussed that if you give the oral glucose, then more insulin will be released because of these GLPs and GIPs than the IV glucose. Okay. And similarly, we have discussed other things about these other hormones also. And today we will study about the secretory factors, secretory products for the stomach. Okay. And the first thing will be the intrinsic factors. Okay. And they're released by the parietal cells of the stomach. You guys already know. Okay. What is their function? Their function is to bind the vitamin B12. Okay. And ultimately, with the help of this binder, the vitamin B12 will be absorbed in the ileum. Okay. So intrinsic factors, they basically secrete some the basically kind of binders which are which bind to the vitamin B12 so that the vitamin B12 could be absorbed in the ileum. Okay. In case of autoimmune diseases, the destruction of these cells can occur, and as a result, the intrinsic factors will be lost, and the patient can get the pernicious anemia, in which the patient has a vitamin B12 deficiency, and because of the vitamin B12 deficiency, the patient can have a megaloblastic type of anemia. Okay, and because in case of autoimmune destruction of parietal cells, you are also losing the acid from the stomach, right? Because the HCl is also secreted by the intrinsic factor. So what you can expect is a very high pH. Okay, negative feedback will be given to the gastrin, and as a result, the gastrin levels will be increased. Okay, and the mass of the parietal cells, it would be decreased. Okay, so a decrease in the mass of parietal cells, increase in pH, increase in gastrin. Okay, and a loss of these intrinsic factors. This is what happens in the autoimmune destruction of parietal cells or atopic gastritis. Okay, now then second comes the gastric acid, which is also released by the parietal cells. Okay, it's actually to decrease the pH of the stomach. Okay, it is increased by the histamine. It is increased by the muscarinic receptors. Okay, which are stimulated by the acetylcholine. Okay, and this ACH is released by the vagus nerve. Okay, it is also increased by the gastrin. Somatostatins, they will decrease it. Okay, GIPs, they will decrease it. Okay, prostaglandins, they will also decrease it, and that's why the prostaglandins are kind of protective. Okay, from the gastritis or the ulcers. Okay, and secretin also inhibits it. Then comes the pepsin. For the pepsin, it is released by the chief cells. And does anyone remember the gland name where the chief cells are present?
Parathyroid.
No, I mean, yes, of course, at the parathyroid, but in the stomach.
Deep layer.
Of which gland?
Oxyntic.
Oxyntic glands. Okay, don't forget that you have two types of glands: the oxyntic glands and the pyloric glands. Okay, in the oxyntic glands you have the chief cells. In the pyloric gland you have the somatostatin releasing cells. Okay, so they help with the protein digestion because they release the pepsin. Okay, it is released in the inactivated form, which is a pepsinogen. Stomach pH, which is the acidic pH, help activating this enzyme. Okay, and it is released by the vagal stimulations and the local acid. Okay, then finally the bicarbonate, which is secreted by the mucosal cells. Okay, and these cells are also present in the duodenum. Okay, you also have the Brunner's gland in the duodenum. Yes. Okay, you have some you have the mucosal cells in the salivary glands in the pancreas. They also release the bicarbonate. Okay, so all the function of the bicarbonate is to neutralize the acid. So please know the location. The mucous neck cells in the stomach, they release the bicarbonate. In the duodenum, you have the mucosal cells as well as the Brunner's gland. They both releases the bicarbonate, okay, and then in the salivary glands and also in the pancreas you have the bicarbonate secreting cells, okay, and yeah, the secretion of bicarbonate is by the release of secretin, very important. Remember two type of secretions from the pancreas. One is the enzymatic secretion and one is the bicarbonate secretion. The bicarbonate secretion is by the enzyme, or sorry, by the hormone secretin, right? And the release of enzyme is by the hormone. Which hormone?
Cholecystokinin.
Yes, exactly. Very important. So this is a structure of a normal stomach gland. Okay, this is the oxyntic gland. As you can see, it has a superficial layers. It has a deep layer, right? It has initially the gastric pits. As you can see here, these are the gastric pits. Okay, these are the surface epitheliums. Okay, these are the mucus cells which are releasing the mucus. Okay, they're filled with mucus completely. In between, you have the parietal cells. As you can see, these parietal cells are eosinophilic, kind of red or pink, right? And the chief cells are basophilic, okay, the purple or bluish. Okay, then you have the enterochromaffin cells. Okay, these cells that releases the histamine. The function of enterochromaffin cells is to release the histamine, and they do that in response to gastrin. Okay, and gastrin is released by the gastrin releasing peptide, which is released by the vagus nerve. So whenever a vagus stimulation is there, okay, the vagus nerve releases two things. One is the acetylcholine and second is the gastrin, right? Gastrin, it will act on the enterochromaffin cells to release the histamine, as well as the parietal cells has the receptors for the gastrin also. Okay, so by the direct means and by the indirect means, it will release the acid from this from these cells, right? And the vagal stimulations directly with the help of acetylcholine, they will release the acid again, right? So that's how this thing works. You have three phases of the gastric acid secretion, right? One is the cephalic phase, second is the gastric phase, and third is the intestinal phase. For the cephalic phase, okay, the acid will be released with a thought, smell, or sight. Okay, whenever you think about food, whenever you see a food, whenever you smell something, okay, the acid will be released in your stomach, and this is known as the cephalic phase. For the gastric phase, whenever the food, okay, enters the stomach, it will stress the stomach. Okay, what does it cause? It will cause a distension of the stomach, right? And because of this distension, the acid will be released, right? And this is known as the gastric phase. Finally, the intestinal phase, whenever the acidic kind enters the duodenum, okay, it need to be neutralized, right? So as a result, multiple hormones will be released like secretin, okay, and like other hormones also, and they will inhibit the gastric acid secretion. Okay, so in intestinal phase, the gastric acid secretion will be decreased, while in the cephalic and the gastric phase, the acid production will be increased. Okay, remember these three phases. They will ask you in which phase the acid will be reduced. Okay, so this will be the intestinal phase. Any doubt on this page?
No, thank you.
And this is what we have discussed already now. Okay, how the acid is released. See the vagus nerve. Okay, it releases the acetylcholine, as you can see here. As you can see also where it is releasing the acetylcholine. Same time, it will be also releasing the gastrin releasing peptides. Okay, the gastrin releasing peptides will be acting on the G cells to release the gastrin. Okay, the gastrin that works on the enterochromaffin cells to release the histamine, as well as the gastrin can directly stimulate the parietal cells to release the acid. Okay, the vagus nerve, which by releasing the acetylcholine, it will stimulate the parietal cells to release the acid directly, as well as the intrinsic factors. That's how the acid is released in the stomach. Okay, and yeah, that would be all. Whenever the vagus nerve acting on the D cells, as you can see, okay, they will inhibit the release of somatostatins first, right? Important. Okay, whenever the vagus nerve stimulates the B cells, it will inhibit the somatostatin release. Okay, from the mucous neck cells, you can see the mucus is being released. Okay, I cells, they were releasing the CCK hormone, S cells, the secretin, and K cells, the GIP. Okay, and yeah, that would be all the location of different secretory cells in the GI tract. Okay, and gastrin majorly works on the ECL to release the histamine so that the acid would be released rather than the direct effect of the on the parietal cells. Okay, so it has more indirect effect than the direct effect for the acid release. Any doubt on this part?
No. Thank you.
Okay, just give me a second. Yeah. Now let's talk about the pancreatic secretions. Okay, and we're going to talk about the enzymatic secretions mainly, right? So first enzyme will be the alpha amylase. Okay, as the name suggests, it is the amylase, which is the starch digesting enzyme. Okay, it is always secreted in the activated form. Okay, second is the lipases. Okay, lipases for the lipid digestion, for the fat digestion, right? And they're also secreted in the activated form, right? Then you have the proteases. Okay, and these are for the protein digestion. And now because the pancreas itself is made up of proteins, right, for the protein building blocks, so you need to secrete these enzymes in the inactivated form so that they won't damage the pancreatic parenchyma, right? And that's why they will be released in the inactivated form known as the zymogens. Okay, now whenever these zymogens reach the duodenum, okay, the duodenum has the enterokinase or the enteropeptidase enzyme. Okay, and know the location of this enzyme. Very important. Stephen will ask you at what site these enzymes will be activated, right? So it is the brush border epithelium on the duodenum and the jejunum. The brush border epithelium on the duodenum and jejunum. Okay. So this enteropeptidase or the enterokinase, it will first activate the trypsinogen to the trypsin. And once the trypsin is activated, it will convert the chymotrypsinogen into the chymotrypsin. Okay. And the procarboxypeptidase into the carboxypeptidase. Now, because of this trypsin, because of the activated trypsin, right, other enzymes could be activated like the this chymotrypsin and the carboxypeptidases and the elastases also. Okay, this is very important. And the trypsin is also activates itself. Okay, it is kind of a positive feedback loop. Whenever a trypsin is being is present, it will convert the trypsinogen into the more trypsin, right? Like a positive feedback loop. Now, some amount of these proteases, especially the trypsinogen, can get activated into the pancreas also. Okay, but you have certain mechanisms, okay, which will inhibit these enzymes as soon as they get activated. Okay, some of them, some amount of the trypsinogen can get activated inside the pancreas, but you have some mechanisms, some protective mechanisms which will inhibit these activated enzymes, right? And failure of these protective mechanisms can lead to the pancreatitis. Okay, because if these enzymes get activated in the pancreas, then they will digest the pancreas completely, right? And they will cause the pancreatitis. So you have some protective mechanisms present already. If not, then you can have a acute pancreatitis, right? You also need to know about the bicarbonate secretion. Okay, whenever you have a high flow rate, see, you have these pumps, the chlorine and the bicarbonate pump. So whenever the chlorine is more, the bicarbonate will be less. And whenever the bicarbonate is more, the chlorine will be less, right? So in a low flow, okay, these pumps will be less activated, and hence the high chlorine will be present in the secretion and low bicarbonate. Whenever the flow is increased, which is increased by the action of secretin, okay, you have a very high bicarbonate and a very low chlorine. Okay, and the concentration of sodium and potassium is same as that of plasma concentration. Okay, so for the fluid secretion, okay, whenever you have a low flow, you will have a high chlorine content, high chloride ion content. Okay, whenever you have a high bicarbonate content, and it is by the action of secretin, okay, which increase the concentration of bicarbonate and decrease the concentration of chloride, which has happened by the chloride and the bicarbonate pumps. Okay, very important. Any doubts so far?
Could you please explain why low flow and high flow are associated with different concentrations of chloride and bicarb?
It's just about the activation of the pumps. Okay, you have the chlorine pump, you have the bicarbonate pump. Whenever the secretin is there, the pump will be activated, the flow will be increased, right? And as a result, you will get the high concentrations. It's just about the pumps.
Okay, good. Thank you.
Okay, now let's talk about the carbohydrate absorption. Okay, like we have discussed, you have the SGLT1 transporters in the GIT and SGLT2 transporters in the, name the location,
Kidney.
kidney, in the PCT of the kidney, right? And again, you have the GLUT5 receptors. And does anyone know what this GLUT5 receptors does? We have discussed that.
Fructose.
They will cause the absorption of the fructose. So you have the GLUT5 receptors, which will cause the absorption of the fructose. Okay, you have the SGLT1 transporters, which will cause the sodium and the glucose absorption. Okay, then you have the sodium potassium ATPase pump on the basolateral membrane, and they will cause the outflux of three sodium and the influx of 2 potassium, and these are the pumps which are creating the gradient for the absorption of this sodium and the glucose, right? Now, when the glucose is being absorbed and the fructose is also absorbed, now with the help of GLUT2 receptors, they could be reabsorbed in the, they could be enter into the circulation, right, with the help of GLUT2 receptors. So GLUT5 action first and the SGLT1 action first, then the action of GLUT2 receptors. Okay, very important. And only monosaccharides can be reabsorbed, no polysaccharides. Okay, and that's why you have the alpha amylase enzyme and other enzymes which will digest the polysaccharides into the monosaccharides first, right? You have the lactase enzyme which will convert a disaccharide, okay, into the monosaccharides, right? And that's why whenever you lose these enzymes, you will lose the digestion of these saccharides, right? Now comes the D-xylose test. Xylose is basically a simple sugar, okay, which do not require any enzyme for the absorption. Okay, it just requires surface area. So whenever the surface area is present, okay, the xylose could be absorbed and we will have a normal test. Okay, whenever the surface area is damaged, like in case of a GI mucosal damage, right, from any infection, like in case of a gastroenteritis, like the rotavirus infection or any parasitic infection or any bacterial infection, okay, then you will have a damage of the GI mucosa. In that case, you cannot absorb the xylose, okay, because you do not require any enzyme, but just the surface area. So in these scenarios where you are damaging, where your GI mucosa is being damaged, okay, in that case, you will lose the D-xylose and you will have a negative test. Okay, so this test is very helpful in differentiating the cause of the the malabsorption, whether it is an enzyme deficiency or it is a real mucosal damage, right? So very important, the D-xylose test. Okay. Any doubt on that part?
No, thank you.
Then you have the absorption of the vitamins and the other minerals. Okay. First, let's talk about the iron. Okay, the iron will be most absorbed in the duodenum. Okay, very important. And for that, you have the iron along with the food. Okay, it could be of two type, either the heme iron or the non-heme iron, right? The heme iron will be absorbed more than the non-heme iron because this non-heme iron will be converted into the Fe2 plus form first, and then it could be absorbed in the GI tract, right? So heme iron will be absorbed more than the non-heme iron. When this iron is absorbed, they will be stored in the ferritin. Very important. Whenever you want to store the iron intercellularly, you have to store that into the ferritin. Okay, now this iron will be waiting into the enterocytes for the absorption in the blood. Okay, and the absorption will be by the ferroportin 1. Very important, right? And yeah, and these receptors through which the iron is absorbed in the enterocytes, these are known as the DMT1 receptors. So these receptors through which the iron is absorbed into the enterocytes, these are known as the DMT1 receptors. Okay, very important to note the name. Now, once the iron is absorbed by the DMT1 receptors, it will be stored into the enterocytes, okay, within the ferritin. Now, this iron will be waiting for the ferroportin to pass, from the ferroportin to pass, right? Now, it is regulated by the hepcidin. Whenever the hepcidin is more, it will inhibit the ferroportin so that all the iron would be stored in the enterocytes. Okay, and when the enterocytes die, the iron will be lost along with them. Okay, and whenever the hepcidin is not there, these ferroportin ones could be activated, and as a result, the absorption of this iron could be happen in the blood, right? And now within the blood, this iron will be transported with the help of transferrin. So ferritin is the storing protein, and transferrin is the transferring protein for the iron. Okay, within the macrophages, within the bone marrow, within any cell, if you want to store the iron, you need to store that in the ferritin only. Is that okay?
Yes.
Now you have a disease which is known as the hemochromatosis, okay, in which the HFE gene is mutated, right? Now this HFE gene is coded for some protein, right, which will interact with two things. Okay, first is the liver. It will go to the liver and it will cause the release of hepcidin. Okay, and second are the enterocytes. In the enterocytes, this not the hepcidin, but this HFE protein, which is coded by the HFE gene, it will interact with these DMT1 receptors to inhibit the absorption of the iron, and as a result, the iron will be lost. Okay, so in the scenarios where you get the mutated HFE, okay, now this protein cannot, can never be this interact with the DMT1 receptors and can never be causes the release of hepcidin, and as a result you have a massive iron absorption. Okay, and that can lead to the iron overload status, right? And this is what happening in the hemochromatosis. You have the increased iron absorption by the DMT1, by the ferroportin, and you have a low hepcidin levels. Okay, so whenever the hepcidin is there, the absorption can happen within the enterocytes, but this iron can never enter the blood circulation. Whenever the HFE protein is there, even the absorption within the enterocytes can never happen. Okay, very important. Is that clear?
Could you please repeat once the action on hepcidin and DMT1?
See, the HFE gene is coding for a protein, the HFE protein, which will interact with the DMT1 receptors and the liver. On the liver, it will release the hepcidin. Okay, and on the enterocytes, it will inhibit the DMT1 receptor so that the absorption of iron can never happen. Okay.
Okay.
And yeah, that would be it.
Okay, yeah, got it.
It just inhibiting the absorption of the iron from the DMT1 receptors. Okay, and second, the hepcidin. Hepcidin inhibits the ferroportin. So even if the iron is absorbed in the enterocyte, it can never enter the blood circulation. Okay.
Yeah. Okay, thank you.
Second is the folate, and it is small. It is absorbed throughout the small bowel, the duodenum, jejunum, ileum. Okay, and the third one is the vitamin B12. Okay, now vitamin B12 will be absorbed in the terminal ileum. Okay, along with the bile salts, and it requires the intrinsic factor. So what happens whenever you ingest the vitamin B12 from the diet? Okay, it will be binded to the animal protein, right? Now this animal protein along with the vitamin B12, it will enter the stomach, right? In the stomach, with the action of the enzyme, the pepsin, right? It will digest the animal protein and it will release the vitamin B12 in the stomach. Okay, now this vitamin B12 will be binded to the R binder. Okay, something, a protein known as the R binder. Now, vitamin B12 is released from the animal protein and is binded to the R binder. Now, this R binder will be go to the duodenum. Okay, from the duodenum by the action of other proteases. Okay, from the pancreatic proteases, the R binder is also released from the vitamin B12. Now the free vitamin B12 is along with the intrinsic factor will go to the ileum, okay, and these intrinsic factors work like a receptor activators, okay. The intrinsic factors will will interact with the vitamin B12 receptors and causes the absorption of vitamin B12, right? Is that okay? First you require the pepsin, okay, so that the vitamin B12 could be released from the animal protein, okay. Then the R binder would be attached with the vitamin B12 in the stomach. This complex will go to the duodenum by the action of the pancreatic peptidases. Okay, this R binder will be released from the vitamin B12. Now, free vitamin B12 along with the intrinsic factor, it will go to terminal ileum. Okay, these intrinsic factors will interact with the receptors of the vitamin B12 so that the absorption of vitamin B12 can happen. Right?
Yes.
Okay, so in any anywhere in this pathway, if something happened that will compromise the absorption of vitamin B12, if the pepsinogen is not there, if the acid is not there, if the gastric bypass occur, if the intrinsic factors are lost, if the damage to terminal ileum happen, in all of these scenarios, you can have a vitamin B12 deficiency. Okay, very important. Now a disease which is known as the short bowel syndrome, or known as the short bowel disease. Whenever you cause the resection of the small intestine, due to any kind of inflammation, let's take an example of the Crohn's disease. In case of Crohn's disease, you are having chronic inflammation of the GI tract. Okay, and the only solution is to cause the resection of the ileum or other areas, right? In that case, you will be shortening the length of the short bowel, small, okay, of your small bowel, right? And as a result, because the length is short, now less time will be present for the absorption of the substances like the vitamin B12 or the folate or the iron, right? And because of this less time, only few or a little amount of these nutrients could be absorbed in the GI tract. So you will get a deficiency of these nutrients. Okay, and second thing, because of less absorption, okay, what's gonna happen? The diarrhea will be happen, and this is known as the short bowel syndrome. Very important. Okay, it happens whenever you do a surgery for the small bowel, right, for the small intestine. Okay, that will shorten the length of the small intestine, and as a result, the absorption will be decreased. And what you will get is the diarrhea, okay, malabsorption, deficiency of these nutrients. Is that okay? Short bowel syndrome.
Yeah.
So it would be seen the patient with a gastroduodenectomy. Okay, it could be seen with the ileal resection. They will ask you why the patient is having diarrhea because of a loss of distance or a decrease in the distance or length of the bowel, right? So that the absorption can never happen. Second is the bacterial overgrowth syndrome, or the SIBO. Okay, it is happens whenever you do a gastric bypass surgery. Okay, so that a bacterial overgrowth can happen in the in the blended portion of the intestine. Like say, you have this stomach, right? And then you have the intestine completely. Now, for the gastric bypass surgeries or any others, these bypass surgeries, what's gonna happen? You will connect the part of stomach or other areas of the intestine directly with the duodenum or jejunum or ileum, right? Bypassing this whole segment, right? And this whole segment will be ended in a blended pouch because you will disconnect these two segments. This segment will be ended like a blended pouch, and this part is will be connected like that. So a direct connection will be happen between the stomach and the duodenum. Is that okay? And now because of this blended portion, okay, you can have a bacterial overgrowth in that area, right? You can have a bacterial overgrowth in that area, and that can that can cause an increased release of vitamin K, because you guys know that vitamin K will be released by the bacteria, right? So they can cause the vitamin K increase. They will also increase the folic acid production in the GI tract. So what you will get is an increased vitamin K, okay, and the increased folic acid production. Right now, because of the hyperproliferation of these bacteria, our immune system will be activated, okay, and other toxins will be released by these bacteria that will cause the malabsorption of other nutrients like the iron and the vitamin B12. Very important. Because of the diarrhea, you will lose your iron, you will lose your vitamin B12, the malabsorption can happen. So this is the bacterial overgrowth syndrome, okay, in which you have a hyperproliferation of the bacteria or the overgrowth of the bacteria. Okay, so they will ask you what nutrients can become deficient in this scenario. This would be the calcium, the iron, the vitamin B12. Okay, so you need to give the supplements of these nutrients to these patients, right? But you do not need to give the supplement for the vitamin K or the folic acid because they will be released by the bacteria. Is that okay? Yeah, this thing also happened. Both things are happening. First thing, the vitamin B12 is being lost in the GI tract, and second thing, the vitamin B12 they also feed on the the bacteria. They also feed on the vitamin B12, right? So both the reasons are there because of the loss of vitamin B12 because of malabsorption of it, and second thing because of the feeding of the bacteria on the vitamin B12, you will ultimately has a deficiency of vitamin B12, right?
Yeah. Okay. Thank you.
So that would be all about the iron, folate, and the vitamin B12 absorption. In case of a fat malabsorption, you will have to give the patient vitamin A, D, E, K. In case of any gastric bypass surgeries in which you are losing your intrinsic factors and the acid, you need to give the patient supplements for vitamin B12, right? Please remember these facts. For the malabsorption, fat soluble vitamins should be given. For the bypass surgeries, especially the gastric bypass surgeries or the rejection of ileum, you need to give the patient vitamin B12 first. Okay, then the pair patches, okay, which are only present in the ileum. These are the lymphoid aggregates. Okay, these pair patches, they contain the specialized type of cells known as the M cells, which are the antigen presenting cells. Okay, whenever a new antigen enters the GI tract, they will cause the endocytosis of these antigens. Okay, and they will present these antigens to the immune cell in the pair patches. Okay, and the immune cells, especially the B cells in the pair patches, they will be transformed into the plasma cells, and these plasma cells they will be releasing the IgA antibodies, the circulating IgA antibodies. With the help of a process known as a transcytosis, they will cross the epithelium from the basal to the apical side, right, and they will enter into the lumen of the GI tract, the IgA antibodies. You have a bacteria known as a Shigella, which will be taken up by the M cell, right? But what happens? It will escape the presentation by degrading the phagocytic vacuole. And when it escapes, it will enter a cytoplasm. There it will hack the actin tubules. Okay, and one kind of tubules, the actin are
Intermediate.
not the intermediate,
Microfilaments.
microfilaments. Okay, they will hack these microfilaments. Okay, and with the help of the actin, it will enter to the adjacent enterocytes. Okay, because M cells are present in between the enterocytes, right? So by hacking this actin, it will enter the adjacent enterocyte and there it will cause a necrosis. And because of this necrosis, you're having the inflammation. So inflammation in the Shigella is not because these M cells are presenting them to the pair patches and the immune response is happening against Shigella, right? It is not like that. The inflammation is because of the necrosis of the enterocytes. Okay, because it will escape the antigen presentation, Shigella, very important, right? And what cells are responsible for the microbial flora? Uh, you know, uh, what cells actually checking the microbial flora in the GI tract?
Plasma cells.
No, 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 not the plasma cells. Which cells are responsible for the regulation of the microbial flora? Yes, what cells? Regulation of microbial flora is done by what cells in our body? Yeah, Punnett cells. Good. Okay, so don't forget the difference between the M cells. M cells for the antigen presentation and Punnett cells is for the microbial flora regulation, right? And then you have the pair patches. Is that okay?
Yes.
Okay.
Can you repeat the presentation of M cells process?
You have the pair patches, which are lymphoid aggregates. Above them, you have the M cells, right? And adjacent to M cells are the enterocytes. Okay. Whenever a new antigen is entered in the GI tract, okay, these Punnett cells will causes the endocytosis of this antigen, right? This antigen will be entered inside the cell within the endosome, right? And this endosome will be presented to the pair patches, to the B lymphocytes and the T lymphocytes, first of course, to the T lymphocytes. Okay, and then the response against this antigen can be generated. In case of Shigella, okay, the Shigella will be entered into the M cell for the presentation to the pair patches. But what happens? It will escape this presentation by causing a destruction in the phagosome. Okay, it will escape out. It will replicate within the cytoplasm. Okay, it will hack the actin microfilaments. By hacking the actin microfilaments, it will enter to the adjacent enterocytes, right, and causes the necrosis of these cells. And whenever the necrosis happen, it will always followed by the inflammation by the neutrophils, right? So you will have a necrosis, you will have this inflammation with the neutrophils, right? And you will have all this blurry diarrhea, right? And the neutrophilia and all of these things. Is that okay now?
Yeah, it's okay. Thank you so much.
Okay, then you have the bile. Okay, and does anyone remember why you need the bile in the body?
Emulsification of fat.
Emulsification of fat, yes. So the composition of bile is basically nothing but just the bile acids which are conjugated to the glycine and taurine. Okay, because bile salts are kind of bile acids which are conjugated to the glycine and taurine to make them water soluble. Because initially the bile acids, these are lipid soluble, okay, not the water soluble. So to make them the water soluble, you need to combine them with the glycine and taurine. Okay, inside the bile you have the cholesterol, you have the bilirubin, you have the water, you have the phospholipids, you have the iron, right? And a very crucial step or a very important enzyme for the synthesis of the bile is the 7-alpha hydroxylase. And this is a final step and also the rate limiting step for the bile acid synthesis because it is the slowest enzyme. The rate of the whole reaction or the complete process of formation of the bile is dependent upon the speed of this reaction, right? The speed of this enzyme. So that's why it is the rate limiting step. The function is to cause the digestion and the absorption of the lipids and the fat soluble vitamins. Okay. Cholesterol excretion from the body. It is the primary means of excretion of cholesterol. And third thing is the antimicrobial activity. Three things: antimicrobial activity, okay, the cholesterol excretion, okay, and the absorption of fats and the fat soluble vitamins. All of these three things are done by the bile salts. Okay. In case of any short bowel syndrome, which we have discussed already, in the Crohn's disease, okay, it will prevent the normal fat absorption because it will cause uh, you know, a loss of absorption or decrease in absorption of the enteric bile salts. Okay, very important. Whenever you have a fatty diarrhea, let's say, whenever you have a short bowel syndrome, whenever you have a Crohn's disease, the bile salts will be lost in the ileum, right? So it will prevent the absorption of a normal fat. Now, what happens is normally the calcium binds to the oxalate. Okay, in the GI tract, the calcium binds to the oxalate. Okay, and as a result, the absorption of the oxalate can never happen because of the calcium oxalate formation. Okay, the absorption of oxalate will not happen in the GI tract. But because the fat is being lost in the GI tract in this scenario, all of the calcium with the help of a reaction known as saponification, okay, all of the calcium will be binded to the fats now, okay, and as a result, the oxalate is free. The oxalate will be absorbed in the GI tract, okay, it will enter into the circulation, it will reach to the kidneys, okay, and there in the kidneys, this oxalate will be combined to the calcium to form the calcium oxalate stone, and that's why in the Crohn's disease you can have a calcium oxalate stones because of increased absorption of the oxalate by the GI tract. Is that okay?
Yes, yes.
So don't forget the reason for the calcium oxalate stone in the Crohn's disease. It is because of fat malabsorption, so that all of the calcium binded to the fat. Oxalate is free, it will enter circulation, it will go to the kidney, and there it can form the stones. Is that okay up to here?
Yeah, yeah.
Okay, then let's talk about the bilirubin. Okay, bilirubin. First you have the RBCs. Okay, in the RBCs you have the hemoglobin. Whenever a RBC ruptures, okay, the hemoglobin will be released. Okay, it has heme and the globin part. Globin is basically a protein, so it will be a kind of reused again. Okay, heme is made up of which substances? Heme is made up of
Iron and porphyrin.
iron and the porphyrin. Yes. So the iron and the porphyrin, because iron uh, is a nutrient, it could be reused again. Okay. Now this porphyrin, it will be converted into the unconjugated bilirubin. Okay, very important. It will be converted into the unconjugated bilirubin, right? Before the bilirubin, it will be first converted into the biliverdin, okay, which is by the enzyme heme oxygenase. So working on this heme is an enzyme which causes the oxidation of this heme known as the heme oxygenase, right? By the oxidation, we will be converting this heme into the biliverdin first, right? And then this biliverdin will be converted into the bilirubin via a reduction reaction. Okay. Now this unconjugated bilirubin is this is not a water soluble protein or a substance, right? So it will enter the bloodstream and it will bind to the albumin, which is a protein carrier. Okay, it is a protein which is a carrier of certain nutrients, okay, and certain substances, certain drugs, and one of them is the bilirubin, right? So albumin and the unconjugated bilirubin complex is formed, okay, and all of this bilirubin will be transferred to the liver. In the liver, you have the enzyme known as a UDP glucuronidase transferase enzyme, UDP glucuronidase transferase, and it will convert the unconjugated bilirubin into the conjugated bilirubin. Okay, this conjugated bilirubin will be entered into the bile. Okay, from the bile, it will reach to the GI tract, right? With the action of the GI tract, all of this conjugated bilirubin will be converted into the urobilinogen first. Now, this urobilinogen will be enter into the this urobilinogen can be go two ways. Okay, first is the reabsorption back into circulation. From there, it can go to the kidneys and to the liver, right? And second way is to be excreted from the body. Okay. Now, 80% of the urobilinogen will be converted into the stercobilin first by the action of other bacteria. Okay. Now, this stercobilin is responsible for the color of the stools and it will be excreted from the body. Remember the name stercobilin. Okay. Formed by the urobilinogen. Okay. Now, 20% of this urobilinogen will be entered into the circulation again. Right. It will go to the kidneys. Okay. And within the kidneys, this urobilinogen will be converted into the urobilin. Okay, it will be converted into the urobilin, which will be excreted in the urine, giving the urine a yellow color. Right, the 90% of this urobilinogen will be go back to the liver via entire hepatic circulation, and again it will go into the GI tract. Okay, is that okay up to here about the function about this the unconjugated bilirubin? Then the conjugated, then the urobilinogen. In the feces, it would be stercobilin. In the kidney, it would be urobilin. In the liver, it can be entered back by the enterohepatic circulation. Is that okay?
Yeah.
Now, whenever you have an obstructive jaundice, okay, now listen carefully. Whenever you have an obstructive jaundice, in that case, this conjugated bilirubin can never enter the GI tract and can never be converted into the urobilinogen. Is that okay?
Yes.
Okay. Now, because this conjugated bilirubin will never enter the GI tract and never become urobilinogen, it cannot be converted into the stercobilin, right? And as a result, your feces won't have the stercobilin, won't have the color, the yellowish color. Is that okay?
Yes.
So what you will have something known as the very alcoholic stools, which are very light color stools. Okay, that is the first thing. Second thing, because the urobilin wasn't there, it cannot be converted into the urobilin again. Is that okay?
Yeah.
So you won't even have the urobilin in the urine. So what thing actually gives the yellow color to the urine in case of obstructive jaundice if the urobilin is not there?
Conjugated bilirubin.
Now this conjugated bilirubin, it will enter the blood circulation and it will go to the kidneys. It will be excreted by the kidneys and it will give a very deep red color to the urine. Okay, not a lightish yellow color, but a very deep red color, a deep yellow color to the urine because of this conjugated bilirubin. And that's why you need to measure the, that's why you need to do the conjugated bilirubin test for the urine. Okay, if the test is positive, that means you are having a conjugated bilirubin in the kidney, which shouldn't be there at the first place if there wasn't any obstruction. Okay, so please remember, conjugated bilirubin won't be there in the kidney normally. Okay, it would be the urobilin. But in case of any obstructive jaundice, the urobilin won't be there in the kidney, but the conjugated bilirubin instead. So whenever you do the test for the conjugated bilirubin, it will come out to be positive. So don't be surprised. Okay, because sometimes it could be a confusion. Okay, so it is not the conjugated bilirubin but the urobilin. Very important. So whenever you do the conjugated bilirubin test, it will come out positive, which should not be happen in the normal individual. In the normal individual, if you test the urine for the conjugated bilirubin, it will come out negative, of course. Is that okay?
Yes.
Good. That's everything on this page. We have discussed the hemochromatosis. We have discussed the hepcidin. Okay. And yeah, the gastric bypass procedures, they will cause a vitamin B12 deficiency first. For the malabsorption syndromes, they will cause the vitamin A, D, E, K deficiency first. Okay.
Yeah.
Just give me a second. Okay, so we are done with the physiology of the GI tract. Any doubt of the physiology, you can ask.
No, thank you.
So now let's start the GI tract pathology. And first is the sialolithiasis, which is a stone in the salivary glands. Okay, so whenever the secretion or the flow is decreased, okay, any dehydration occurs, okay, that can lead to the formation of stones, right? Very important. Whenever the dehydration occurs, flow will be decreased, right? And that can lead to the formation of stones. And whenever the stone formation occur, it can block the salivary glands, right? And whenever a blockage happen, it can lead to the bacterial overgrowth. It can lead to the increase in the pressure, okay? And it can lead to the ischemia and necrosis and inflammation of the gland or the tissue, right? So in case of cellular lithiasis, okay, it will be happen in three major glands, okay, which are first one is the parotid, second is the submandibular, and third is the sublingual. The most common is the submandibular gland. Okay, it has a Warthin's duct, very important. Okay, whenever the stone is there, okay, it will block the gland completely. Okay, and whenever you try to eat something, okay, you will have a pain, right? Because these glands need to release the saliva, and because the obstruction is there, okay, the pressure inside the glands will be increased. As a result, whenever the pressure is increased, the blood supply will be compromised. Because of high pressure, you will get the ischemia, and because of this ischemia, you will get the pain. Okay, so these cerulithiasis will always present as the recurrent preparental pain. Okay, and the swelling in the affected gland because of the ischemia, because of the sometimes the bacterial inflammation. Okay, you can have an inflammation in the gland, you can have a swelling of the affected gland. Okay, which could be visible on the outside. It will be seen as a swelling at the angle of the jaw, for say, right? Causes, it includes a dehydration, it includes a trauma. Okay, you need to give the patient anti-inflammatory drugs like the NSAIDs. Okay, you will do the glands massage. Okay, you will do the warm compressions, and sour candies would be very helpful because they will increase the salivary flow. Whenever the salivary flow is increased, although the pressure is also increased, the pain will be increased too. But because of this increased flow, these stones could be passed, right? And because of the increased flow, it is a kind of protective factor, right? Because a decrease in the flow and the dehydration are the risk factors. Is that okay up to here?
Yes.
Whenever the stone is there, that can lead to the inflammation, and this is known as the sialadenitis. Okay, sialadenitis. It is an inflammation of the salivary glands due to the obstruction. Now, because of the obstruction, the pressure before the obstruction will be increased. As a result, the blood supply will be compromised. Okay, sometimes the bacterial this infection can also happen. The bacterial this growth can happen, and most commonly the Staphylococcus aureus is responsible for it. Okay, you can have an infection, or this inflammation can also happen with the immune mediated mechanism or the autoimmune disorders. Okay, and how this inflammation present you with? It will present you with the swelling of pores. Okay, if it is a parotid gland, then it can lead to the parotitis. Okay, it will be present as the post-auricular swelling, which will be extended to the mandible. Okay, and whenever the inflammation is there, there will be destruction of the cells, so that all the enzyme inside these cells will be released. Okay, one of the marker of the cellular destruction is the LDH, so the LDH levels will be raised. Second thing, because these glands contain the amylases, the salivary amylases, right? So the level of these salivary amylases will be high, right? And you also need to understand that both in the pancreatitis as well as in the as well as the sialadenitis, you will have a high level of amylases, right? Because both the pancreas and the salivary glands contain the amylase. But in pancreatitis, you also have the high levels of lipases, right? So a high level of lipases, high level of amylases, along with the pancreatitis, okay, you cannot suspect the sialadenitis in that case, right? But whenever you have a high amylase level without any evidence of the pancreatitis, that means it is an inflammation of salivary glands, right? So just know the risk factors, know the important cause, know the symptoms, right? Know the treatment, these four things. Is that okay?
Yes.
I had two questions. A,
Yes.
with if you're getting inflammation, how are we getting ischemia? And secondarily, what is the when you say diagnosis confirmed by imaging CT, what's the thing you have written after CT?
CT for the face. In
No,
that you
no,
will, yeah.
the
Acha, the USC ultrasound.
oh, okay.
Okay, first thing you can do is a CT where you will check for the, the swelling in the gland if it's there. Okay, it would be visible in the CT. Okay, then you can check the ultrasound for the stones, for the thickening of the walls, right? If the wall thickening is there for the salivary glands, that means it is an inflammation, right? So
Okay.
these two things will confirm the diagnosis. And what was the other question?
If you have inflammation, how are we also getting ischemia?
No. Because of the ischemia, you are having inflammation, not because of inflammation, you are having ischemia.
Oh, okay. So the stones cause ischemia, which cause inflammation.
Yeah, stone will cause the increase in pressure within the glands, and whenever the pressure is increased, the blood supply will be compromised, right? And this will cause inflammation or and ischemia, right?
Yeah. Okay. And my last question was, I thought that your sublingual gland was the one with the most salivary glands. So then why is or is that wrong? Because it says submandibular is the most common for cytolithiasis.
We don't know why it is more common, but it is more common.
All right.
Just a data suggests that it is more common.
Sure. Thank you.
Yeah. Okay, now let's talk about the salivary glands tumor. Okay, and the most common location of the salivary glands tumor is the parotid glands. Almost 80 to 85% times it would be a parotid gland swelling. Okay, they will present as a painless mass or a painless swelling. Very important. If they are benign, then they won't cause any symptom. Okay, they will be sometimes asymptomatic. Sometimes they will present just a painless swelling. If they are malignant, okay, then they will cause an overgrowth of the tumor and they will compress the facial nerve. Does anyone know the location of parotid glands?
Near the temporal mandibular joint.
Okay, and this facial nerve just passes deep to the glands, right?
Yeah.
So whenever you have an overgrowth or a hyperplasia, something, okay, and most specifically, if you have a malignant cancer of this parotid gland, then it will causes the involvement of the facial nerve also. It will compress the facial nerve and it can cause the facial nerve paralysis. Okay, so please remember, the facial nerve paralysis is is an important complication of the malignant tumors, right? So that's how you will differentiate between the malignant tumor and the benign tumor. If the facial paralysis is there, that means it is a benign. That means it is a malignant tumor. If the facial paralysis is not there, which means the Bell palsy was absent, the patient was normal just with a swelling, that means it could be a tumor, a benign tumor. Okay. The most common type is the pleomorphic adenoma, okay, which is a benign mixed type tumor. Okay. It is composed of the epithelium. It is composed of the chondromyxoid stroma. Okay. And it will reoccur if it is not incompletely exercised. Which means even if you do the surgery, okay, just give me a second. Yeah. So where are we? So if you do the surgery and somehow some part of the tumor is kind of left behind without excision, right? If the incomplete excision occur, then again it can regenerate the whole cancer. Okay, very important. So you need to do the surgery very carefully. You need to excise, every component of the tumor completely, right? And this tumor can also undergo the malignant transformation. Okay, so just remember, the common tumor. It has a chondromyxoid stroma. It has the epithelium, two components, and if it is incompletely excised, it can lead to the regeneration of the tumor completely, right? Second is the mucoepidermoid carcinoma, which is a very malignant tumor. Okay, it has a mucinous and the squamous component. So whenever you have a salivary gland tumor and you see a mucin-rich tumor in it, that means it must be the mucoepidermoid carcinoma. Okay. Third one, which is the most important type, is the Warthin's tumor, also known as the papillary cyst adenoma, lymphomatosum, papillary cyst adenoma. Okay, lymphomatosum. Okay, it is a benign cystic tumor. It is only seen in the smokers. Okay, and when you do the biopsy, you can see the germinal centers. Very important. So whenever you see two hints for the cancer, first is the smoking, and second is the germinal centers. Okay, with a swelling in the face. Okay, for the gland, that means it is a Warthin's tumor. Okay, very important. So the germinal centers and the smoking for the Warthin's tumor. Is that okay for the tumors?
Yes.
Then comes achalasia. We have discussed that already. In case of achalasia, you are having a destruction of the nitric oxide and the VIP releasing neurons, which are the parasympathetic neuron part. And when the nitric oxide and the VIP is lost, you cannot have the relaxation of sphincters, especially the lower esophageal sphincter. So because of this hypercontraction of the lower esophageal sphincter, whenever you eat the food, it cannot enter into the stomach. It will remain in the esophagus. Okay, the food will be start accumulating within the esophagus, and as a result, the dilation of the esophagus will happen. It is known as a dilated esophagus, as you can see here. And here is our obstruction. As you can see, beyond the obstruction, everything is kind of very much narrowed. Okay, before the obstruction, everything is dilated because of this accumulation of the food. If you do the manometry findings, which in which you will check for the pressure changes inside the esophagus whenever you ingest a food, okay, you will see uncoordinated or the absent paralysis in the lower part of the esophagus. Because of this accumulation of the food and the dilation of the esophagus, you will have a very minimal or the absent paralysis in the lower part of the esophagus. In the upper part, everything would be normal. Okay, you will have a normal contraction of the upper esophageal sphincter. You will have a normal contraction uh, uh, in the in the proximal esophagus. Everything would be normal. Okay, because it is made up of this striated muscles, which will still cause the contraction, right? The amplitude of the peristalsis will keep on decreasing as you go from proximal to the distal esophagus, right? And in the distal esophagus, you will lose all of your paralysis, okay? And the tone of the LES will be very much high. The tone will be increased and the paralysis will be lost. The peristalsis will be lost. This is what you find in the manometry. You will have a progressive dysphagia to the solid. First, you will have the dysphagia to the solid foods, okay, and then you will even have the dysphagia for the liquid foods, right? So it would be a progressive type of dysphagia, not the acute type. First, the solid foods will be there, and then the dysphagia for the liquids will be there. And when you do the barium swallow, you can even see the dilated esophagus, which will be seen as the bird beak sign. Okay, and it is associated with the increased risk of esophageal cancer. Now, if you remember the microbiology lectures, in the parasite section, we have discussed about the achalasia, right? About the Chagas disease, which is a cause of the achalasia. Remember? The
Yeah.
Trypanosoma cruzi. The Chagas disease, it can cause the achalasia. It can cause the megacolon. It can cause the dilated cardiomyopathy. And what kind of dilated cardiomyopathy this Chagas disease can do?
Apical.
Apical, very important, right? So please remember this thing. And whenever you have an acute infection with a Trypanosoma cruzi, it will always present as a unilateral swelling of the eye. And for the chronic infection, you will have the dilated cardiomyopathy, you will have a megacolon, you will have a achalasia, right? And it is because of a destruction of the neurons which are releasing the nitric oxide and the VIP, which are the parasympathetic neurons. Okay, and where does these neurons present? In the Orbeck plexus, because if you guys remember, in the submucosal area, okay, the plexus is responsible for the release of the secretions, right? And this plexus is known as the mesenteric plexus, right? In the muscles, you need the peristalsis, right? You need the peristalsis in the muscles, you need the contraction of muscles, right? So the plexus which is present in the muscles will be responsible for that, okay, for the contraction and for the relaxation. The plexus which is present in the muscles, which is the Orbeck plexus or the myenteric plexus, it would be responsible for that. So neurons which are present in these plexus will be damaged, and that can lead to the achalasia. Is that okay? Yes.
Is it Meissner's plexus or only myenteric plexus?
In case of achalasia,
Yeah.
it is only the myenteric plexus, because the contraction of muscles happens whenever these plexes are involved, right? For the contraction or relaxation of the muscles, the Orbeck plexus is responsible. Meissner's plexus is responsible for the secretion only, not for the contraction. Okay.
Okay. Okay. Thank you.
So a damage to the neurons within the Orbeck or the myenteric plexus. it will happen, right? And other important thing is the globus sensation, okay, which is kind of similar to the achalasia. The patient will have a sensation of dysphagia, a sensation of something stuck in the throat, okay, but it is all psychological. Everything is normal, structurally is normal, the pressure is normal, okay, food is going normally within the esophagus and then entering in the stomach. So everything is normal. It's just a sensation of something, of a foreign body being stuck in the throat. Okay, so it is an abnormal sensation and fullness in the throat, like something getting stuck in the throat. The patient will complain. Okay, and it always worsens with the swelling of the saliva. Whenever you swallow the saliva, the sensation can get worse, right? But everything is normal. Okay, it is not due to any kind of structural abnormality. It is not due to any kind of motility disorder. Okay, and significant pain or dysphagia or any kind of abnormality or any kind of systemic symptoms which could be present in the cancer won't be there, right? So whenever you encounter a patient who is having just the complaint of this of something getting stuck in the throat, okay, but every test came out to be normal, that means it is a globus sensation. Okay, while in case of any other disease, like in case of achalasia, you can have abnormal barium swallow test. In case of any cancer which can cause a dysphagia, you can have a systemic signs and symptoms, right? You can have a pain, okay, if there is some kind of this GERD or anything like that, right? So if everything is normal, just a sensation is present, that means it is a global sensation. Is that okay?
Yeah.
Okay, so we will take a short break here, okay, and then meet up again.
Okay.
Let's discuss about the esophageal pathologies. Okay. Before that, one more thing. Right. Oh, yeah, that's it. Okay, so let's discuss the esophageal pathologies. Okay. For that, first, we have the diffuse esophageal spasm. And as this name suggests, in this case, we have a diffuse spasms, okay, of the esophagus. And throughout the esophagus, you will have the spasms. It is a non-peristaltic, or you can say uncoordinated contractions of the esophagus. Okay, you have a normal lower esophageal sphincter pressure, which means this sphincter would be absolutely normal. It just whenever you ingest a food, okay, you will have a diffuse contraction of the esophagus at the same time, and as a result, the food, it cannot go upward, it cannot go downward, it will stuck at the location. Okay, so the patient will always present with a this sensation of something getting stuck in the throat, same as that of gloma sensations. You will get the feeling of something getting stuck in the throat, right? But it is not just a psychological thing, it is a kind of a mechanical damage to your neurons, which is causing a non-peristaltic or you can say the uncoordinated contractions of the esophagus. Whenever you ingest something, diffuse spasms of throughout the esophagus will occur, and that can lead to the dysphagia. Okay, you will get the angina-like chest pain, you will get the dysphagia, right? And whenever you do the barium swallow, it will reveal the corkscrew esophagus. Very important. When you do the barium swallow, it will reveal the corkscrew esophagus. Okay, and just give me a second. And this is a corkscrew esophagus. Okay, as you can see, kind of spring-like appearance. Okay, or you can say apple peel type appearance of the esophagus. Okay, this is shown in the, this could be seen in the diffuse esophageal spasms. When you do the endoscopy, as you can see, when you do the endoscopy of the esophagus, you will see these kind of structures. Okay, something like going in this pattern. Okay, the corkscrew esophagus. Is that okay?
Yes.
Yeah.
So this is what you see in the diffuse esophageal spasms. Okay, so what are the treatments? Because it is a spasm, it is a smooth muscle contraction. The treatment would be to dilate the smooth muscles. This could be done with the help of nitrates and the calcium channel blockers. Okay, very important. Second is the eosinophilic esophagitis, which means the inflammation of the esophagus. And in this inflammation, eosinophils are involved. And because the eosinophils are involved, it is kind of a hypersensitivity reaction. Okay, it is generally seen in those individuals which have history of another hypersensitivity reactions. Okay, like any food allergy, like any history of asthma, okay, like any history of urticaria or something like that. So whenever you encounter a patient who is having a family history or a previous history of asthma or any kind of food allergy, okay, or any kind of allergy, not just a food allergy, okay, only in those individuals, you will suspect the eosinophilic esophagitis. Okay, it is the inflammation of the esophagus. Okay, what you will see is a dysphagia. Of course, first thing will be a dysphagia. Okay, we'll have the food impactation, a sensation of something getting stuck in the mouth or in the throat. Okay, second thing, whenever you do the endoscopy, right, or when you remove the food particle, okay, from this esophagus, which was stuck there, okay, what you will see first thing would be the linear furrows. Okay, first thing would be the linear furrows. Second thing is the rings. Okay, rings will be formed on that food particles, or rings could be seen even in this endoscopy. Okay, second thing would be the linear furrows would be seen. Okay, and third thing would be the whitish whitish plaques on the food particle, which is the eosinophilic microabscesses. Okay, very important. Three things. Okay, first are the rings, second is the linear furrows, and third thing is the eosinophilic microabscesses, which is present as a whitish plaques or papules over the food particle that you removed, which was stuck in the throat or in the esophagus. Okay, and when you do the biopsy, on the biopsy you will see numerous eosinophils. Okay, and it will present as a dysphagia, a sensation of getting stuck in the throat. Okay, you will have a chest pain also. Okay, you will have a reflex vomiting because it is a dysphagia. Whenever the food particle getting stuck in the esophagus, it will be thrown out. So you will get the vomiting, you will get the sensation of food stuck, right? You will get the chest pain also, you will get a dysphagia, right? And so it could mimic something like the GERD. Okay, but the only thing that you can do first is, of course, the histology. Okay, you will do the biopsy, so you will see numerous eosinophils. Okay, second thing is basically whenever you give the patient GERD therapy, like the proton pump inhibitors, okay, it won't cause any relief to the patient. Okay, so this thing is kind of unresponsive to the GERD therapy. So whenever you encounter a patient, okay, who is having some symptoms for the GERD, okay, and you give the patient proton pump inhibitors, even after giving the PPIs, okay, it won't resolve the patient's symptom. That means it is a eosinophilic esophagitis. Or if giving the patient PPIs, okay, it will provide the patient relief. That means it is a GERD, not the eosinophilic esophagitis. Because eosinophilia you can have both in the GERD and as well as in the eosinophilic esophagitis. So when the biopsy won't help you much, the only thing is the proton pump inhibitors. If the relief is there, that means it is a GERD. If the relief is not there, that means it is a eosinophilic esophagitis. Okay, any doubt? And along with the history of any atopic condition like the asthma or any food allergy, okay, it will confirm the diagnosis of your eosinophilic esophagitis, not the GERD. Okay. Yeah.
Yeah.
Third thing is the esophageal perforation. Okay, which means a complete rupture of the of this esophagus. Okay, most commonly it is iatrogenic. Okay, that can be happen during the any kind of surgery or any kind of endoscopy when you're performing, or any sometimes a nasogastric tube passage or something like that, it can cause a damage to the esophagus. It will cause a perforation in the esophagus. And as a result, all of the air which is present in the esophagus, it will be leaked out. Okay, and it can cause the pneumomediastinum. Okay, which is the air in the mediastinum. As you can see, this is the aortic arch and these are the lungs. Air should not be present outside the lungs. But as you can see in this condition, the air is present adjacent to the aortic arch, right? And this is known as the pneumomediastinum. Whenever you have a free air within the thorax, right? This is a pneumomediastinum. So how it can present you? It can present you with the subcutaneous emphysema. Whenever you do the auscultation, you can have a subcutaneous crepitus. Okay, you can have a subcutaneous crepitus, which is a very important sign suggesting the patient is having a air within the skin, within the subcutaneous tissue. You are having the area, and which is a very important sign for the esophageal perforation. Please remember, it is a complete damage of the wall. Okay, a transmural rupture occur, right? And yeah, non-iatrogenic causes includes a spontaneous rupture, any foreign body ingestion, any trauma, any kind of malignancy can do that. Okay, you can have a dysphagia because of it. You can have a voice change because of the free air. You will have a crepitus. Very important thing, right? And when you do that chest X-ray, you can even see the air bubbles in the neck of the patient, right? Or when you do the CT, you can have a air bubbles outside the lungs, right? And then other syndrome is the Bohave syndrome. Okay, Bohave syndrome, it is basically a transmural rupture again because of a violent retaching. Okay, it could be happen because of vomiting. That could be seen in the alcoholics, right? Or it could be seen in the bulimic patients, okay, who do regular vomiting. So because of the vomiting, because of an increased pressure in the abdominal cavity, it can lead to an increased pressure in the esophagus. And because of this increased pressure, the esophagus can damage completely. And this is known as the Bohave syndrome. Is that okay?
Yes.
Okay. Then comes the esophageal strictures, okay, which generally happen with some kind of acid reflux, okay, any kind of inflammation, you can say, any kind of inflammation to the esophagus, okay. And whenever, the stem cells are damaged, then only one way you can have a wound healing, which is the fibrosis, right? So a fibrotic structure is formed within the esophagus, okay, that will block the lumen of the esophagus. This is known as the esophageal strictures. Whenever you have an inflammation, you have a damage, okay, wound healing is happened by the fibrosis, and that can lead to the stricture formation. So esophagitis or other cause of esophagitis, okay, like the acid reflux, like the caustic ingestion, or any kind of inflammation can lead to the esophageal strictures. You will have a dysphagia. Again, you will have a sensation of food stuck. Okay. Then comes the esophageal varices, which you guys already know. It is seen in the portal hypertension. Whenever you have an increased pressure or the volume overload in the portal circulation, okay, then what's gonna happen? You will have the drainage of all this venous blood by the esophageal veins. Okay, and this anastomosis happened between the esophageal veins and the left gastric vein, right? Because of the anastomosis, you will have a dilation of the esophageal veins, and because of the dilation, you can have the esophageal varices, right? You will have the leakage of the blood from these veins, and you can have a life-threatening hemorrhage. Okay, it can lead to a life-threatening hematmesis, right? And generally seen in the cirrhosis or any case of portal hypertension, right? And it is generally seen in the lower 1/3 of the esophagus because this anastomosis between the portal circulation and the esophageal veins happen in the lower part of the esophagus. Just remember the veins name which are involved. These are the left gastric vein, which drain the blood in the portal circulation, and the esophageal veins which drain the blood into the azygous vein and then to the inferior vena cava. So all of the blood which were initially going to the portal circulation, it will be uh, diverted to the esophageal veins, right? So that the veins will be dilated because of this volume overload, and that can lead to the esophageal varices. Is that okay?
Yeah.
And when you do the when you do the endoscopy of the patient, you can even see these tortuous veins, as you can see. This is something you will see in the endoscopy of the patient, the tortuous veins. Okay, and what is the treatment for the esophageal varices?
Octreotide.
And second,
Ligation.
ligation is not that much easy. You have to beta blockers, yes. Good. Okay, now comes the esophagitis, which is the inflammation of the esophagus, right? And any kind of virus, any kind of acid, any kind of caustic ingestion, right? Any this eosinophilic esophagitis even, like they can cause the inflammation of the esophagus, right? So whenever you have an inflammation of the esophagus, you will have a pain with the ingestion, right? A painful ingestion would be there, right? Dysphagia can happen because of this loss of function of the esophagus, the peristalsis loss will occur, right? So first we need to know about the causes. One is the acid reflux, okay, which is seen in the guide. Second thing, in the immunocompromised patient, you can have a three infections. One is the candida, one is the herpes simplex virus 1, and second is a cytomegalovirus infection. We have discussed already in the microbiome section. For the candida, you will have a this erythematous base, and over this base, you will have a whitish plaques, which are scrapable type. Okay, when you do the endoscopy, what you will see is the whitish plaques. As you can see this, these are the whitish plaques you will see. And when you remove these plaques, you will see the erythematous area, okay, at the base of these plaques, right? Second thing is the herpes simplex virus 1. Okay, when you do the endoscopy of the patient, you can see the punched out ulcers, okay, which is seen like that, just like this, circular, in a very circular patterns, you will see. These are the punched out ulcers in this shape, circular shape ulcers, you can say, right? This you will see in the herpes simplex virus 1. In case of cytomegalovirus, whenever you have an infection of CMV anywhere in the GI tract, you will always have the linear ulcers. Even if you have a colitis, you will have a linear ulcers in the colitis. For esophagitis, you will have a linear ulcers in the esophagitis, right? So linear for the cytomegalovirus. The caustic ingestion can do that. Sometimes drug-induced esophagitis can happen. We have discussed all the causes already while discussing the chapters. Like in the antimicrobials, we have discussed about these tetracycline drugs. Remember, they can cause the esophagitis. For the musculoskeletal, we will discuss about the biphosphonates, right? They can cause the esophagitis. What other side effect these drugs can cause? The biphosphonates,
GERD.
biphosphonates.
Esophagitis, esophagitis.
Esophagitis is a side effect. Other side effects,
Jaw necrosis?
necrosis of the jaw, right? Very important, right? Other drugs includes the NSAIDs, they can cause it, right? Iron ingestion can cause it, and potassium chloride, they can cause it. So remember all of these causes. Okay, for the antimicrobials, you have the tetracyclines. Okay, for the musculoskeletal, you will have the biphosphonates. For the nutrients, you have the this iron and the potassium chloride, right? And the tetracyclines can, and the NSAIDs can cause the esophagitis. You will have the pain with the swallowing, right? And the pain with the swallowing is known as, anyone remember?
Odynophagia.
Odynophagia, yes. You call it the odynophagia. Okay. So remember the name, pain with the swelling will happen, right? And because the patient will eat less, so the patient can also have a weight loss, right? You will also have a burning chest pain sometimes along with the dysphagia, right? And epigastric tenderness. Remember, I told you, whenever any kind of condition, any inflammation or anything involving your foregut structures, they will always causes the epigastric pain, right? So you will have an epigastric pain, you will have a pain with the swallowing, right? You will have a weight loss, you will have a chest pain, you will have a burning sensations. These are all for the esophagitis. Same things can happen with the GERD, and you guys also know that GERD can cause esophagitis, right? So that's why all of these symptoms can even mimic the GERD. So now let's discuss about the gastroesophageal reflux disease, or the GERD, right? In this case, you will have a very lower esophageal sphincter tone. Okay, the sphincter is being compromised, and as a result, all of the acid along with the food will be regurgitating back into the esophagus, right? And then to your throat, your mouth, your back of the mouth. Okay, so what symptoms you will see? First, because of acid reflux, you can have a heartburn. Because of the acid reflux, you can have a esophagitis. You will have a pain with the swallowing because of the inflammation, right? You will have a weight loss. You will have a dysphagia, right? You will have a regurgitation. And sometimes the regurgitation, even you can taste the acid back into your mouth. Okay, so it will be a acid taste, a very sour taste, you can see. You will have an erosion of the enamel because of the acid. right? You will, and because you have a chronic reflux of the acid, okay, then metaplasia of the esophagus will happen at the GE junction, okay, and these squamous cells is now converted into the columnar cells that you can easily see in the endoscopy, right? And because the healing of this inflammation will happen after with the fibrosis, okay, what you can see is the stricture formations also, and because of the stricture formation, you can have a further dysphagia, right? You will have the hoarseness because of the laryngopharyngeal reflex. Because of the regurgitation, sometimes a small amount of this food will enter into your respiratory tract and can reach to your lungs, right? So spasm can happen and that can lead to the hoarseness, right? And this thing can associate with the asthma also, right? And yeah, that would be it. So symptoms would be a chronic dry cough, right? Symptoms would be a pain with the swallowing, right? Symptoms would be a heartburn, right? Sour taste on the back of the teeth, right? Enamel erosion would be there. Weight loss would be there, right? On the endoscopy, you can see the erosions at multiple places in the esophagus. You will have the metaplasia in the GE junction, right? And yeah, does anyone can tell me why you are having this dry cough in case of this GERD?
Irritation of the vocal cords.
And not the major cause. Other important one.
Aspiration of food particles.
Exactly, because of aspiration of the food particles, you're having inflammation within the lungs also, right? And that can lead to the chronic cough. A dry cough would be there, especially the nighttime cough. Okay, because in nighttime you have a very high parasympathetic activity, right? You will have a vagal stimulation which can cause a more acid release. So the symptoms will be more prominent in the night. You will have a nighttime dry cough. You will have a nighttime heartburn, regurgitation after the food can happen when you ingest the food. Okay, dinophagia will happen and all these things. So when you do the biopsy of the lung in case of a GERD, okay, what you can see are the neutrophils and the lipid-laden macrophages. Because these food particles contain the fat, the macrophages in the lungs will cause the ingestion of these fats and become the lipid-laden cells. So you will see the neutrophils because of the inflammation. You will see the lipid-laden macrophages on the biopsy of the lung in case of a GERD patient. Is that okay?
Yeah.
So that's all about the GERD. So what is the treatment of the GERD? It would be the proton pump inhibitors, right? And when you do the manometry test, you will see a very low esophageal sphincter tone. Okay, the peristalsis would be kind of normal, or and they could be reduced at the lower esophagus, but the tone, the sphincter tone will be very much reduced, right? This is the most important thing, right? And yeah, see, same kind of manometry finding could also be seen in the achalasia. In the achalasia, you have a normal upper esophageal peristalsis, right? And you will have a loss of peristalsis in the lower esophagus. Similarly, in the upper esophagus, you will have a normal peristalsis in the GERD. In the lower esophagus, you will have a absence of the peristalsis in the GERD. But the most important thing to differentiate between the achalasia and the GERD is the esophageal tone, sphincter tone, right? Sphincter tone is very much high in case of achalasia and very much low in case of GERD. Is that okay?
Yes.
Then you have a Mallory-Weiss syndrome, which is a partial thickness erosions, or I can say the laceration, not erosion, partial thickness laceration of the esophagus. See, in case of esophageal perforation, you are having a transmural rupture of the esophagus, a complete rupture. In case of Mallory-Weiss syndrome, you are having a partial thickness rupture, okay, and these ruptures are confined to the mucosa and the submucosa. And whenever these ruptures, okay, whenever they become transmural, okay, now this Mallory-Weiss syndrome will become the esophageal perforation. Okay, it is generally seen in those conditions in which you have a very high esophageal pressure, okay, and the most important thing will be your vomiting, because whenever you vomit, you will increase the intraluminal pressure within the stomach, within the esophagus. Now, because of this increase in the interluminal pressure, uh, you can have a laceration of the esophagus, right? So it is generally seen in the alcoholic patient, it is generally seen in the bulimics because of increase in the vomiting or increase in the interluminal pressure. So along with this Mallory syndrome, because these patients are generally alcoholics and the bulimics, which do regular vomiting, you can also have a hypochlorhydria and a hypokalemia in these patients. Is that okay?
Yeah.
Because of the vomiting, you can also have a hypochlorhydria and the hypokalemia in these patients, right? And it is only a mucosal and submucosal lacerations. If the lacerations become transmural, then the Bohave syndrome or the esophageal perforation can also happen. Okay.
I have one question.
Yes.
Yeah, when we talk about achlorhydria or hypochlorhydria, we are specifically talking only about stomach, right?
Yes, the loss of acid.
Okay, and the same thing also happens in pernicious anemia also sometimes.
Yeah, exactly. If it is a case of atopic gastritis, which is because of the this autoimmune condition, right?
Yeah. Okay.
So you can have a loss of acid again.
Okay. Thank you.
Okay, then comes a very important one, the Plummer-Vinson syndrome, okay, in which you have a classical triad of the dysphagia first. Because why dysphagia? Because of the esophageal webs or the strictures, I can say, right? These structures can sometimes known as the esophageal webs because of the fibrosis in the esophagus, okay? So first thing is the esophageal webs. Now, because of the esophageal webs, you're having a dysphagia. And along with that, you will have an iron deficiency anemia. So this classical triad known as the Plummer-Vinson syndrome, it is an important cause of iron deficiency anemia, and it increases the risk of esophageal squamous cell carcinoma. Very important, you must know the risk factors for the squamous cell carcinoma and the risk factors for the adenocarcinoma. Stefan will ask you this, right? So Plummer-Vinson syndrome will increase the risk of squamous cell carcinoma. Okay, and remember the strictures, they will also increases the risk of squamous cell carcinoma, right? Very important to note. And GERD can increase the risk of adenocarcinoma. Okay, note the causes. Then comes Shatsky ring. Okay, and these rings are generally formed at the gastroesophageal junction, GE junction, and typically occur due to the chronic acid reflux, which is seen in the GERD. So the complication of GERD include the esophagitis, the Shatsky ring. Okay, and yeah, the Barrett's esophagus. These three are the complications of the GERD. Okay. Then comes the sclerodermal esophageal dysmotility, in which you're having a collagen deposition, a very high collagen deposition, okay, and a destruction of the smooth muscles. Now, because of the destruction of the smooth muscles, why squamous cell carcinoma has achalasia or strictures as a risk factor? Well, I really don't know about that, why the squamous cell carcinoma, but yeah, it is a risk factor.
No, I'm asking like, was strictures a cause of squamous cell cancer or was achalasia cardia the cause of?
Both.
What? Okay.
Both are the cause of it.
Okay, thank you.
Okay, so sclerodermal esophageal dysmotility, which is seen in the scleroderma or the CREST syndrome, in which you have a very high collagen deposition, high fibrosis, right, because of this collagen deposition, and you will have a smooth muscle atrophy. And now, because you guys know that lower 1/3 of the esophagus is made up of this smooth muscles, right? So you will have a very lower esophagus sphincter tone because it is also made up of smooth muscles. You will have a dysmotility, you will have a loss of peristalsis, right? And you will have a acid reflux and dysphagia. You will have a GERD as the complication of this scleroderma. Is that okay? So you will see the stricture formation, you will see the aspirations, you will see the Barrett's esophagus, and these are all a part of CREST syndrome. Is that okay?
Yeah.
So whenever you do the biopsy of the smooth muscles in case of scleroderma, what you will see is the very high collagen deposition. You will see the fibrosis. You will see the atrophy of the smooth muscles. Okay. Then one more syndrome you will have, which is known as the dermatomyositis and the polymyositis, and they causes the damage of the skeletal muscles. Is that okay? And because of a damage of the skeletal muscles, you will have a loss of peristalsis. You will have the dysphagia. But the smooth muscles, because they are absolutely normal, so you won't have any reflux. You will have a normal sphincter. You will have just the dysphagia, right? In case of dermatomyositis or the polymyositis. In case of scleroderma, you will have a dysphagia along with the GERD. that okay?
Yeah.
Yes.
So that's all about the esophageal dysmoralities or any esophageal pathologies. Yeah.
Yes.
Any doubt on this page? Any doubt?
No, thank you.
And can anyone tell me, in case of diffuse esophageal spasm, what neurons are affected? Myenteric or the mucinous plexus?
Myenteric.
Myenteric.
Myenteric, okay, because they're involved with the smooth muscle contraction and relaxation. So if these neurons become affected, they will cause the spasms. And whether it is a parasympathetic ones or a sympathetic ones,
Parasympathetic.
because you're having a spasms, you have a contraction of the muscles, right? Important. So yeah, I think any more thing? No. In the Mallory syndrome, you can even have because of these mucosal tears, you can even have the hematoma. Okay, very important. And versus in case of GERD, because sometimes the Mallory syndrome will present as odynophagia and this burning type of pain, right? Because of this vomiting and all these things. So symptoms can mimic to each other, right? But you will have hematoma only in the Mallory syndrome, while in case of GERD, you won't have any hematoma. You won't have vomiting with the bleeding, right? So it is very specific for the Mallory syndrome in case of esophagus, right? Please
Yeah.
remember that. So in order to differentiate between the eosinophilic esophagitis and the GERD, you need to give the patient drug therapy and check whether the symptoms improved. If the symptoms improved, then it means GERD. If not, then it means it is eosinophilic esophagitis. To differentiate between the Mallory syndrome and the GERD, you will look for the hematoma. If the hematoma is there, that means it is a Mallory syndrome. If if other hints are not given or hints are very much confusing, then you will check for the hematoma, right? If the hematoma is there, that means it is a Mallory syndrome. If the hematoma is not there, that means it is a GERD. Then comes the Barrett's esophagus, which is the intestinal metaplasia. And does anyone remember where does the metaplasia occur in what cells of the tissue? Metaplasia occur?
Stem cells.
Stem cells. Okay, stem cells need to reprogram themselves, and then they will proliferate again, and they will replace the entire tissue with this new tissue, right? And this is known as the metaplasia. And metaplasia occur whenever the stress on that particular tissue is changed completely. The type of stress, whenever it is changed, it can lead to the metaplasia. In case of Barrett's esophagus, because of a continuous reflux of the acid, okay, squamous cells cannot tolerate these conditions, right? So these squamous cells will be replaced by the columnar cells, which are better adaptable to this high acidic environment, right? So the non-keratinized stratified squamous epithelium will be replaced with the non-ciliated columnar epithelial with the goblet cells. And these goblet cells, does anyone remember the function of the goblet cells?
Mucus
Mucus
secretion.
production.
They will secrete the mucus and they will protect the epithelium from the acid, right? So it is seen with the GERD. And it is associated with the increased risk of esophageal adenocarcinoma. Okay. And most of the patients are kind of asymptomatic, right? And they will present with the dysphagia and the weight loss. Dysphagia would be kind of a progressive type. First, you will have dysphagia with the solid foods, and then you will have the dysphagia with the liquid foods. Okay. And if you want to look for the biopsy of the patient, let me just Google it for you. This is a histology of a patient with a Barrett's esophagus. In this area, you can see all of these cells are the stratified squamous epithelium. Okay, you have the stratification, see the multiple layers of the cell. Okay, and these are all the squamous cells, which is the normal esophagus. At the GE junction, okay, you will have the metaplasia of the esophagus, and as you can see, the glands are there. Okay, the crypts are forming here, as you can see. These are the crypts, right? And these are all lined by the epithelial, the columnar epithelial. See the longer cells are there. These longer cells, if I zoom in,
Columnar shape.
as you can see, these see the length of these cells. These are the columnar cells. Okay, so this is the histology of a Barrett's esophagus. At one side, you are seeing all the cells with the squamous epithelium, non-keratinized stratified squamous epithelium. On this side, it is the columnar epithelium. Okay.
Yes.
So that's about the Barrett's esophagus, and it increases the risk of adenocarcinoma. Then let's discuss the esophageal cancers. Esophageal cancers, they always present you with the progressive type of dysphagia, right? And just like any other cancer, you will have a systemic signs and symptoms like the weight loss, fatigue. Okay, these are the most common presenting complaints. Along with the weight loss and the fatigue, the patient can also have a progressive dysphagia, which means the dysphagia first with the solid foods and then the dysphagia with the liquid foods also, right? Why? Because as the tumor grows, it will obstruct the lumen, right? And first it will obstruct the lumen, it will cause a dysphagia for the solids. And when it grow even more, it will cause a complete obstruction of the lumen, and that can cause the liquid food dysphagia also, right? And because the patient cannot take the food, and because the cancer is there, you will have a weight loss, you will have the fatigue also. Okay, and whenever these patients present to the OPD, okay, the cancer is already very much progressed, right? And that's why the patient generally have a very poor prognosis. Okay, because of this tumor, sometimes the bleeding can also occur. Okay, and this can lead to the iron deficiency anemia also. Okay, and yeah, that would be it. And generally, patient will have a history of a very long history of the GERD. Okay, most of the patients generally have a very long history of GERDs. Okay, and yeah. So let's discuss two type of cancers. One is the squamous cell carcinoma, and second is the adenocarcinoma. Please know that upper two-third, okay, upper two-third of the esophagus, they have the squamous cell carcinoma, and in lower one-third of the esophagus, you can have the adenocarcinoma. If you look for the lymphatic drainage for the esophagus, the upper two-third, it will be go to the mediastinal lymph nodes. Okay, and the lower one-third, it will go for the lymph nodes of the
Celiac trunk.
exactly the celiac lymph nodes, which is for the foregut. Every foregut structure, they will be ultimately drained into the celiac lymph nodes, right? And the lower esophagus is a foregut-derived structure, so it will always drain into the celiac lymph node. While for the upper two-third, it will go to the mediastinal lymph nodes, right? So what are the risk factors for the squamous cell carcinoma? It is first the alcohol. Second is any thermal injury, any hot liquids like the coffee. Okay, caustic ingestion can do that. Stricture formation, achalasia, smoking. And please note, achalasia, smoking, right? These two things, it can cause both the adenocarcinoma as well as the squamous cell carcinoma. Okay, smoking and achalasia, it can cause both the squamous cell carcinoma as well as the adenocarcinoma. Second thing is adenocarcinoma. You will already know the GERD, the complication of GERD, the Barrett's esophagus, obesity, right? Because in the obesity, you can have a lower sphincter tone, very much low, right? And that can also cause the GERD, and that can cause the adenocarcinoma, a very easy way to remember, right? Smoking and achalasia, like we have discussed, they can cause both the adenocarcinoma as well as the squamous cell carcinoma. Sometimes the H. pylori infection can also cause it. If you have a very chronic infection, that can cause the damage to the lower esophagus also, and that can lead to the adenocarcinoma as well, right? And all of these lymph will go to the celiac lymph nodes. Okay. And yeah, even the preserved food that contain the N-nitroso, right, like the pickle, right, or like any other preserved food, they also contain these toxins which can cause the squamous cell carcinoma, right? So pickles or any preserved food that contain the N-nitroso, okay, which is kind of a preservative, they can cause the squamous cell carcinoma. Is that okay?
Yeah, yeah.
So that's all about the esophageal cancer. Just know the presentation, know the cause, and know the lymph node name. These three things are important, and the location, the upper two-third or the lower one-third. Then you have a disease which is known as a systemic mastocytosis, in which you are having a mutation in the KIT receptor tyrosine kinase, which is a receptor tyrosine kinase, of course, as the name suggests. Whenever you have a mutation in this receptor, you will have a hyperactivation and the proliferation of the mast cells, right? And whenever you have a mast cell activation, you will have a histamine release. Okay, so all the symptoms are because of the histamine release. The symptoms include the, tell me, whenever you have a histamine, what symptoms you can expect?
Flushing,
Urticaria.
Flushing, urticaria, itching, right?
vasodilation,
Bronchospasms,
hypotension, or
vasodilation,
dilation.
hypotension, shock, right?
Gastric
And other
ulcers.
and another important thing, because you have histamine in the stomach also. If you release the stomach, if you release the histamine in the stomach, then it will cause the increase in the gastric acid, right? And that can even lead to the ulcers. So other important complication is also the gastric ulcers and the diarrhea, right? And one of the important marker for the mast cell degranulation, you guys already know it from the immunology lectures, that it is a tryptase. So you need to check the patient for the tryptase level. If these levels are elevated, that means the mast cell degranulation is there, which means this could be a case of systemic mastocytosis. Is that okay?
Yeah, yeah.
So yeah, that everything on this page. Any doubt on this page?
No, thank you.
Systemic mitosis or mastocytosis overlap with esophageal eosinophilic esophagitis at all?
No, see, eosinophils are different cells. It's not about IgE antibody. Do not confuse between the eosinophils and the IgE antibodies, right? IgE antibodies, they cause the mast cell degranulation, not the eosinophils, right?
Yeah.
In case of type 1 hypersensitivity reaction, your activation, you will have the activation of both the eosinophils and the mast cells because of the IgE antibodies, right? So these are a
Okay.
common link for the mast cells and the eosinophils. But in case of eosinophilic esophagitis, you're having a pure inflammation of the esophagus without any mast cell,
Okay. Okay, that's good. Thank you.
right? So do not confuse between the eosinophils and the IgE antibodies. It is a very important thing, okay?
Yes, thank you.
Okay, now let's discuss. We have completed the esophagus now. Okay. After the esophagus, our food will reach to the stomach, right? And now we're going to discuss all the pathologies which involves the stomach, right? First thing is the gastritis, and gastritis is the inflammation of the stomach. Whenever you have the inflammation, you will have the epigastric pain. Okay. You will have the diarrhea sometimes also, right? So, but the most important thing will be the epigastric pain. That pain can be happen with the food, or the pain can be happen with the fasting, right? First thing is the acute gastritis. As the name suggests, it will always happen very acutely. The patient generally present because symptoms are kind of very much severe type, right? So patient will generally present within 3 to 7 days of the symptoms. Okay, they won't wait much. Okay, first thing would be the NSAIDs, because you guys know the prostaglandins are very important to inhibit the gastric acid secretion, right? So whenever you take the NSAIDs, they will decrease the prostaglandin I2, E2, right, which will decrease the gastric mucosa production, and as a result, the acid will be in the direct contact with the mucosa, right? And as a result, the damage can happen that can lead to the inflammation in the stomach. This can cause acute gastritis. Second thing is the burns. Whenever you have a decreased blood supply to the stomach, because of this decreased blood supply, you can have a ischemia, and because of the ischemia, you can have an inflammation, right? In case of burns, you will have a hypovolemia. Okay, you will have the dehydration, and because of this dehydration, you will have a decreased blood supply to the stomach. You will have a mucosal ischemia, and that can lead to the inflammation, acute gastritis. In case of a brain injury, if you guys remember the Cushing's triad, does anyone remember that Cushing's triad?
A change in blood pressure, respiratory rate.
No.
Hypertension, tachycardia,
And
and I don't remember the third thing.
Irregular breathing.
hypotension or hypertension?
Hyper and bradycardia, hypertension, bradycardia.
Hyper and the, yeah, please remember hyper and the bradycardia. Okay, not the hyper and tachycardia. Okay.
Okay, okay.
It is hypertension and the bradycardia along with the very high intracranial pressure, right? Along with that, you will also have a increased vagal stimulations. And because of the increased vagal stimulations, you will have a high acetylcholine release. And we know that acetylcholine directly stimulate the muscarinic receptors on the parietal cells and they cause the increase in the acid production. So they can cause the inflammation. Is that okay?
Why acetylcholine is increased? Can you please repeat?
Because the vagal stimulation, the vagus nerve, it releases
Mhm.
acetylcholine, right?
And it is
That's why.
stimulating secondary to bradycardia.
Yeah, the parasympathetic system is being activated by the brain.
All right.
And the vagus nerve is a part of parasympathetic system, right?
Right.
That's right. Okay, so these are the causes for the acute gastritis. It is also commonly seen among the alcoholics, right? Very important. Alcoholics can also get the acute gastritis. Okay, and yeah, that's it. So these symptoms will be very much acute. Okay, and the resolution of all these symptoms is also acute. You will have an acute presentation and you will have an acute resolution of the symptoms, right? Then comes the chronic gastritis, in which you have a very chronic inflammation, more than a month, more than 2 months, I must say, right? And because it is a chronic inflammation, it is always involves what kind of cells? Does anyone know? What cells are present in the chronic inflammation? General
Lymphocyte.
pathology, lymphocytes.
Lymphocytes.
This inflammation always involves the lymphocytes. And you guys already know that in case of a chronic inflammation, you will have a destruction as well as simultaneous healing. Is that okay?
Yes.
So in this case, you will have a mucosal inflammation first, a chronic inflammation that involves the lymphocytes. Okay, it can often lead to the atrophy of the tissue. You will have a hypochlorhydria. You will have a hypergastrinemia. Why? Because this inflammation can damage the parietal cells, right? And whenever the parietal cells are damaged, it will lead to the hypochlorhydria and the hypergastrinemia. Because of the negative feedback, because of a reflex increase in the gastrin, right? And because of this high gastrin level, you will also have a hyperplasia of the mucosa, okay, of the stomach. And because of this inflammation, you will also have an intestinal metaplasia. And you guys already know, whenever you have a hyperplasia, whenever you have a metaplasia, it always increases the risk of cancer. So this chronic gastritis actually increases the risk of cancers. Is that okay?
Yes.
Yes.
And how does a patient with a chronic gastritis present you? They will always present you with a mild abdominal pain, mild epigastric pain for a very prolonged period of time, like 2 months or 3 months. Because the pain is not severe, they generally do not present to the OPD. They present it very late. Okay, when the symptoms become very chronic, very irritable, then they check for the OPD.
Pain can be present with or without food, right? In case of gastritis.
It depends on the location, right?
All right.
If the inflammation is involving the duodenum, then the symptoms will be different. If the inflammation is involving the stomach only, then the presentation will be different. Okay, so two important causes. One is the H. pylori, and you guys already know that H. pylori only colonizes the antrum. Is that okay?
Yes.
Yes.
So inflammation in case of chronic gastritis, in case of H. pylori, it always involve only the antrum part. Okay, rest of the stomach is absolutely normal. It just because of the inflammation in the antrum, you're having this chronic gastritis. Okay, and the first thing this H. pylori do will be to damage the what cells? We have discussed that already.
G cell.
D cells, the delta cells, right?
Yeah.
So that the somatostatin will be lost, and as a result, you will have a very high gastrin levels. You will have a very high acid secretion, right? And because of this high acid secretion, you can have an inflammation in the stomach also in the later stages, right? So initially, so for the H. pylori, you always need to do the biopsy of the antrum to check for the inflammation and to check for the bacteria, right? And because of this inflammation, you can have a loss of somatostatins and a very high acid production. It will increase the risk of peptic ulcer disease. See, the ulcers are different and the inflammations are different. In case of inflammation, you are not having any kind of erosion. Just the inflammation is there. You will have a erythematous area. You will have a swelling. So how you can visualize this inflammation? You will do the endoscopy, right? And when you do the endoscopy, you can see the erythematous area in the GI tract. In this case, in the stomach. Okay, in the antrum, you will have a swelling in the antrum. You will have a erythematous area in the antrum, right? And you will have a pain, the tenderness in the antrum also, right? Once you have a very high acid production, you can have ulcers, and ulcers would be visible in the endoscopy very easily, right? And so, yeah, the increased risk of peptic ulcer disease and the increased risk of mild lymphoma, which is a marginal lymphoma, okay? And yeah, it first affect the antrum and then it will colonize the stomach. And when it colonizes the stomach, it will cause the inflammation throughout the stomach. And when it colonizes the stomach, it will damage, because of the inflammation, the parietal cells will be damaged, right? And what you will have is the low acids. So in case of H. pylori, initially you will have a very high acid production, but in the later stages, you will have a very low acid production because of a damage to the parietal cells. Initially, the ulcers or the inflammation is because of a very high acid levels, okay? And this happened in the duodenum, right? In case of gastric ulcer in H. pylori, it is because of the inflammation itself, not because of the acid. Is that okay?
Yeah.
Okay, so please remember the causes of the ulcers in case of H. pylori. Initially because of high acid production, and in later stages you will have ulcers within the stomach also. Okay, and that's all because of the inflammation, not because of high acid. Second is the autoimmune gastritis, in which you have a damage to the parietal cells completely. You will have a low acid, you will have a very high pH, right? It will affect the fundus or the body of the stomach first. You will have a damage to the parietal cells, so you will lose the intrinsic factors. You will have a increased risk of pernicious anemia and the adenocarcinoma of the stomach. Is that okay?
Yes, yes.
So these are two things for the acute gastritis and the chronic gastritis. Okay, now, then you have a Menetrier disease. Okay, very important one, in which you have a high TGF alpha. See, it is not high TGF beta, but a high TGF alpha. Because of this high TGF alpha, the cytokine, it can lead to the hyperplasia of the gastric mucosa. And you guys already know that the function of gastric mucosa is to release the mucin and to and to protect the stomach from the acid, right? Now, because of this hyperplasia, okay, first thing you will see on the endoscopy is the high rages. Okay, you will have a very high mucosal folds within the stomach because of the hyperplasia of the mucosa. You will have a very high mucus production. Okay, and that can lead to the protein loss and the parietal cell atrophy, right? You will have a decrease in the acid production. And if you guys remember, if you take the proton pump therapy, right, in that case, you will have very high gastrin production, and that can also lead to an increase in the parietal cell mass or the hyperplasia, I must say, right? So both in the gastrin release as well as in the Menetrier's disease, you will have a hyperplasia of the mucosa, and that can lead to an increase in the mucosal fluids. So how you will differentiate between the gastrin production and this Menetrier's disease? It is to check for the acid levels. If you have a high acid level, that means it is a high gastrin, okay? Or you can say in case of a soluble ulcer syndrome, also you will have a this high mucosal folds, okay? In case of Menetrier's disease, you will have a loss of acid production, right? So this is a very important thing. It is precancerous. It can lead to the cancer ultimately, right? And yeah, that would be it. So know the difference between the Menetrier's disease and the soluble ulcer syndrome. In both of them, you will have a high gastric rage, you will have a high mucosal folds, but the difference is in the acid production. If the acid production is more, then it is the soluble ulcer syndrome. If the acid production is inhibited, that means it is a Menetrier's disease. Is that okay? Know the cause, very important. So you will have a vomiting, you will have anorexia, you will have a weight loss, you will have epigastric pain, you will have the edema. Edema, why? Because of the protein loss. You will lose the protein digestion, right? Is that okay? Yeah.
I have a question.
Yes.
Why there is decreased gastrin in Meniere's disease?
You will have high gastrin, no doubt. You will have a high gastrin levels in the Meniere's disease also.
So how would we differentiate between two, like between
Acid
Meniere's?
production. See, that's why I told you, in case of both the ZD syndrome and the Meniere's disease, you will have a high gastrin level. Okay, you will have a high this hyperplasia of the mucosa. The only thing you can do is to check for the acid levels. If the acid level is high, that means it is a normal ZD syndrome. If the acid level is low, that means it is a Meniere's disease.
Okay, thank you so much.
Okay, in both of the, as you can see in the in this figure also, see the increase in the wall thickness is there. The wall is very much thickened in the stomach, and the rages are increased, right?
Yeah. Looks like
In
brain.
both, yeah, in both of the ZD syndrome and the Meniere's disease, you can see this. But the only difference is in the acid production level.
Okay, thank you so much.
Now comes the gastric cancer. Okay, the most common one is the gastric adenocarcinoma, because of course your stomach is lined by the columnar cells, which can lead to the adenocarcinoma. Okay. And other tumors of the gastric cancers, they includes the lymphoma, because your stomach has the lymph nodes, the celiac lymph nodes, right? So they can cause a lymphoma. Okay, you will have a GI stromal tumor also. And if you guys remember the endocrine lecture, we have discussed the carcinoid syndrome, right? In that we have discussed the GI tract can have a carcinoid syndrome and the lungs can have a carcinoid syndrome. In the GI tract, you can also have a gastric cancer as the carcinoid syndrome, right? So adenocarcinoma, lymphoma, GI stromal tumor, and the carcinomas. These are the 4 types of cancers you can see in the gastric cancer list, right? And generally, all of these patients are kind of asymptomatic, right? But like any other cancer, they will present you with the weight loss. They will present you with the fatigue, right? And because the pathology is involving the foregut, okay, the pain will be happen to the epigastrium. Okay, so it would be a patient having an epigastric pain, right? You will have you will have a early satiety, because because of this cancer, it will be using the lumen of the stomach, right? So lumen size will be decreased. What you will have is the very low accommodation of the food, or the early satiety. So early satiety, epigastric pain, weight loss, fatigue, right? These are the symptoms for the gastric cancer, right? Okay, and other associated symptoms, okay, it includes, first is the acanthosis nigricans, very important. Generally, you will see the acanthosis nigricans in case of diabetes mellitus because of high insulin levels, right? You will see the acanthosis nigricans in the PCOS, again, because of the high insulin levels. But these are the benign causes of the acanthosis nigricans. You can have acanthosis nigricans also in case of gastric cancer, a very important cause, right? And does anyone remember what is acanthosis nigricans is?
Dark black patches on the neck.
On the skin folds, you can say, whenever wherever the skin folds are present, you can have a black patches, you can say, on the neck, on the armpits, right, on the axillae, right, and the inguinal regions also. You can have this hyperpigmented patches, right, and a velvety appearance of these patches. Second thing is the Lasser-Tillett sign. Okay, in this Lasser-Tillett sign, does anyone remember what happened?
Sudden eruption of red plaque.
Seborrheic keratosis, which is a solo lesion generally. In case of gastric cancer, you will have a multiple seborrheic keratosis throughout the body of the patient, right? And these are a highly important thing whenever you encounter a patient with a very much with this seborrheic keratosis, many seborrheic keratosis. That means it is a gastric cancer patient. The causes, 2 types of are there. One is the intestinal type, and second is the diffuse type. Okay, the cause for the intestinal type is the H. pylori, right? The adenocarcinoma, because of the H. pylori, is the intestinal type. Okay, it is also happened with the dietary nitrosamines, which is generally seen in the smoked food. So generally patient is from the Japan, Okay, because in Japan they generally uses the smoked food like the smoked fish. Okay, that's why a very high prevalence of this gastric adenocarcinoma is there in the Japan. Okay, step one will likely to ask you this fact. They will give you a patient with a history of cancer, the gastric cancer. They will give you other histories like the one with the Japanese okay, a Japanese patient. The second history could be a smoking. Third history could be other things also. They will ask you what is the most important risk factor for this cancer. They will give you the smoking. They will give you the smoked food. So please note that smoking is a very minor cause of the gastric cancer, right? The major one or the important one includes the nitrosamines, which is found in the smoked food, right? So you will choose the smoked food. Tobacco smoking can also cause it, but it's a very minor cause. Only 1% or 2% of causes are associated with the tobacco. Achlorhydra is a cause. Why achlorhydra? Can anyone tell me?
It would stimulate gastrin and hyperplasia, metaplasia.
Exactly.
lungs.
Yeah, because of and hyperplasia is a very important cause of cancer, right? Second thing is a chronic gastritis, which can be happen because of H. pylori and because of autoimmune gastritis. You can have the gastric cancer, right? It is more commonly seen on the lesser curvature of the stomach. Very important location. It is seen in the lesser curvature of the stomach. Okay, and it would be an ulcer with the raised margins. Okay, whenever you do the endoscopy of the patient and you see a ulcer with a raised or the irregular margins, I must say, you will have a raised margin, you will have the irregular margins. And these are a very highly characteristic feature for the gastric cancer. So whenever you encounter a patient with a peptic ulcer disease, you always need to do the biopsy of the ulcer. Why? Because in both in case of gastric cancer, both in case of peptic ulcer disease, you will have an ulcer only, right? In case of a peptic ulcer disease, you will have an ulcer with the raised margins and the very irregular type of margins. In case of a benign ulcer, okay, it would be a very kind of a regular margins would be there without any raised lesions. Okay, it will be a normal ulcer. It will be just a erythematous base without any irregular surface. A regular surface would be there, a homogeneous type of ulcer you can see, right? So a biopsy is a very important thing whenever you encounter a patient with a peptic ulcer disease, because both the gastric cancer and the peptic ulcer disease, they will have just the ulcer. Okay. Second one is the diffuse type, because in the intestinal type, you will have just a ulcer, which is present as a very specific location. Okay, just only one location. In case of diffuse type, whole stomach will be involved. Okay, you will have a thickening of the stomach. The wall of the stomach will become very thickened. Okay, and this is known as the linitis plastica. It is known as a linitis plastica. Okay, because the stomach has a very lathery appearance. It will mimic like a leather bag. Okay, this linitis plastica is a name for the leather bag that generally people use for the deserts, right? So this is something like that. So the walls of the stomach become very grossly thickened. You can see that on the CT scan of the patient easily, right? And yeah, that's all. So why this happening? Because important thing that it is not associated with the H. pylori, but it is associated with the mutation in the E cadherin. And the E cadherin is the protein which binds two cells together, right? Which joins two cells together, which keeps two cells together. This is the E cadherin. And remember from the general pathology lecture, a cancer cell will always lose the E cadherin so that they can move freely throughout the tissue, right? Yes.
Yeah.
Okay, so a mutation in the ectoderm that will allow the cells to move throughout the stomach, and that's why they will involve the complete stomach. Right? On the biopsy, you will see the signet ring cells, and these signet ring cells are nothing but because of a very high mucus production is there inside the cells, and because of a very high mucus production, the nucleus will be shifted at the periphery, right? And it will appear as a ring appearance. Okay, like a diamond on the ring. This is a ring. And this is a diamond on the ring. So it is something like that, also known as a signet ring. Okay. So just know the cause, which is the mutation. Know the involvement of the lung, which is a diffuse involvement. What you will see on the CT scan of the patient is a diffuse thickening of the stomach wall. What you will see on the endoscopy is not the ulcer, it's just a regular thickening, right? What you will see on the biopsy of the patient is the signet ring cells. Okay, and on the gross examination, it will be a plaque-like infiltration. Okay, very important. For the intestinal type ulcer, you will see for the intestinal type of gastric cancer, you will see just an ulcer on the endoscopy, a ulcer with the raised and irregular margins. When you do the biopsy, you can see this the mitotic structures. You can see the nucleic cytoplasmic ratio, right, and other things for the cancer. Know the causes: H. pylori, nitrosamines, very important one, regular hydra, smoking, and the atopic gastritis. Any doubt on this paragraph up to here?
No, thank you.
And skin manifestations are also very important: acanthosis nigricans and the numerous seborrheic keratosis. Now the lymph node involvement. Okay, the first one is the Virchow node, okay, which is a supraclavicular lymph node. And remember, I told you that whenever you have an involvement of the supraclavicular lymph node, any supraclavicular lymph node, right, the lymphadenopathy of the supraclavicular lymph node always implies a cancerous origin, not an infectious origin. Okay, so whenever you encounter a patient with a supraclavicular lymphadenopathy, it is always a case of cancer, not an inflammation. Second thing is a Kuchenberg tumor. Now, what happened because of the metastasis of this cancer to the ovary? Okay, you will have the cancer in the ovary, in both the ovaries, right? Please note, you will have a metastasis of this tissue, of this diffuse type of gastric cancer to the ovary bilaterally. Okay, and what you can have is the ovarian cancer. Okay, when you do the biopsy of the ovaries in case of Kuchenberg tumor, what you can say is the signet rings again, because it is a metastasis. It is not the primary cancer of the ovaries, it is the metastasis only, right? Third is the Sister Mary Joseph nodules, which are nothing but the para-umbilical metastasis, subcutaneous type. So you will have a lymphadenopathy in the para-umbilical lymph nodes, right? This is known as the Sister Mary Joseph nodules. And the last one is the Blummer cells, which is the metastasis to the pouch of Douglas. Okay, and because the pouch of Douglas is kind of very much anterior to the rectum. Okay, you can easily see that on the digital rectal examination. Okay, you can have the constipation whenever the metastasis happen to the pouch of Douglas. The tumor will proliferate there. It can compress the rectum. It can block the lumen of the rectum, and that can cause the constipation also. When you do the digital rectal examination, you can see the mass within the rectum. Okay, and yeah, this is the blood vessel. So, any doubt to here?
No, thank you.
Okay, one more thing we forgot to discuss is the stress-related mucosal injury. You can also have a gastritis with the stress, because you guys know that along with the stress, your body will always release the cortisol, right? And cortisol inhibit the production of the prostaglandins. So just like the NSAIDs, you can also have a prostaglandin inhibition with the cortisol, and that can lead to the acute gastritis in the stress. Stress by means you can have a shock, for say, you will have the sepsis, you will have the trauma, right? Any kind of a surgery sometimes, any kind of endoscopy sometimes, you can have the this acute gastritis, right? And that can lead to the ulcers that can bleed. Okay, very important. Any doubt on that? Stress related mucosal injuries?
No, thank you.
So it would be a patient who is in the hospital undergoing some kind of examination or some kind of a surgery, or maybe a history with the trauma. And now when you do the nasogastric examination, you will find some blood in the GI tract. So they will ask you, what could be the cause of this bleeding? Okay, so it would be the stress-related mucosal injury.
Why there is an increase in TNF alpha in Meniere's disease?
TNF alpha is a cause of Meniere's disease. It is not a complication, but a cause of this disease.
It is an autoimmune condition or an inflammatory condition?
No, it is not inflammatory. It is not autoimmune. It's just you are having a high level of TGF alpha, which stimulates the growth of this gastric mucosa.
All right.
Okay, now the complication of the peptic ulcer disease, the complication of the gastritis, which is the peptic ulcer disease. Okay, so you two type of, you have the ulcers at two locations. Okay, one is in the duodenum and one is in the stomach itself, right? the ulcers within the stomach are because of the inflammation, like we have already discussed. Whenever you have an inflammation within the stomach, it will damage the mucosa, right? And by damaging the mucosa, you can have the gastric ulcers, right? Now, the duodenal ulcers are because of a high acid production. Because of the high acid production, you will have a damage to the mucosa of the duodenum, and that can lead to the ulcers, right? So let's discuss about the features of these ulcers. First is the pain. Okay, when you eat the food, you will have a high acid production in the stomach, right? And because of that, you will have a you already have an inflammation, first thing, and above the inflammation, just give me a second, guys. See, you're already having the inflammation in the stomach, right? And above the stomach, you're having a high acid production. So whenever you eat the food, because of this high acid production, you can have a more symptoms. You will have a pain, right? So patient with the gastric ulcer, it will present you with the pain after eating. In case of duodenal ulcers, because you guys know that whenever you eat the food, there will be the bicarbonate production. Okay, and this bicarbonate will neutralize the acid, right? So it will help in resolution of the symptoms. Okay, so for the duodenal ulcers, you will have the resolution symptoms with the eating. Okay, and in case of the gastric ulcers, you will have the pain along with the eating, right? Very important difference. Second is the H. pylori infection. See, in case of gastric ulcers, 70% of times it is because of the H. pylori. In case of duodenal ulcers, 90% times it would be because of the H. pylori. Okay. Whenever you have the infection with the H. pylori, initially you will have a very high acid production, right? Because you guys know that H. pylori always colonize the antral area first, antrum first, right? And the inflammation will occur at the antrum, right? It will destroy the somatic, the delta cells, so that a somatostatin won't be released, and you will have a very high gastrin level. You will have a very high acid production. This high acid will enter the duodenum, and in the duodenum, it can cause the ulcers in the proximal part of the duodenum, right? This is for the acute thing, right? In the later stages, this H. pylori, along with the colonization of the antrum, it will colonize the stomach also, the complete stomach, especially at the lesser curvature. Now, because of the colonization of the stomach, you can have an inflammation in the stomach also, okay, along the lesser curvature. And because of the inflammation, you will have a damage to the mucosa, okay, and you will have a gastric ulcers. So in the initial stages, you will have a duodenal ulcers. In the later stages, you will have the gastric ulcer in case of H. pylori. Okay. Other causes of the peptic ulcers in case of duodenal ulcers include the NSAIDs. Okay, when you take the NSAIDs, you will have a low the levels of the prostaglandins, right? Of the prostaglandins, and that's why you will have a very high acid production. High acid will again damage the duodenum. Same thing goes with the therapies with the glucocorticoids, right? They will inhibit the PGE2, and as a result, you will have very high acid productions, right? And the other causes of the peptic ulcer in case of gastric ulcers, it includes the autoimmune gastritis. Okay, that would be it, and the NSAIDs again. Okay. Okay, so we have discussed the mechanism already. In case of gastric ulcers, it is because of the mucosal damage. In case of duodenal ulcers, it is because of the gastric acid production, right? One important cause of the duodenal ulcers includes the Zolliger-Ellison syndrome, in which you will have a very high acid production, and it will damage the distal duodenum and the jejunum. See, the location is very important. Whenever you see the ulcers in the distal duodenum and the jejunum, that means there must be the ZD syndrome. Okay, but whenever you see the proximal ulcers, that means it is a cause it is caused by the H. pylori. Is that okay? So if step 1 describe your ulcer in the distal duodenum, you will always choose a ZD syndrome. If step 1 describe your ulcer in the proximal duodenum, that means you will always choose the H. pylori or the normal gastric ulcer disease. Okay?
Yeah.
Whenever you have a ulcer in the stomach, right? Because you guys know that a gastric adenocarcinoma generally present you with just an ulcer, right? So the gastric ulcer are associated with the increased risk of carcinoma. So whenever you see a patient with a gastric ulcer, you always need to do the biopsy to ensure that this is not caused by that this ulcer is not caused by the cancer. right? But the duodenal ulcers, they are always benign, right? They're always benign. So you do not do you have no need to do the biopsy of the patient in case of duodenal ulcers. Is that okay?
Yes.
Okay, so yeah, that would be all about these ulcers. Any doubts so far?
No, thank you.
Okay, now let's discuss the complications of the ulcers. Okay, so the first complication, the ulcers can bleed because the blood supplies are there. They could be damaged. The vessels could be damaged because of the inflammation. The ulcers could bleed, and that can lead to the gastric bleeding. Okay, and whenever you have a gastric bleeding, you will have a heme within the GI tract. Okay, and this heme will mix with your vomiting, and that can cause a coffee ground emesis, a very dark brown vomiting you will see in these patients because of the GI bleeding. You will have a bloody diarrhea in the patients, a very dark stools it will present as, right? And the patient will also have, because of the bleeding, the patient can have a hemorrhagic shock, right? Is that okay?
I have one question.
Yes.
Why do we have diarrhea in this case?
Bleeding stools, not a diarrhea, bleeding stools mainly.
Okay, thank you.
Okay.
Yeah.
And
thank you.
yeah, second thing, you need to know the bleeding. Okay, it would be the left gastric artery. Very important. The bleeding happened because of the left gastric artery, because you guys know that the gastric ulcer is always located on the lesser curvature, right? And the lesser curvature is supplied by the left gastric artery, right? So you have bleeding from the left gastric artery. Okay, and yeah, and whenever the ulcer is in the duodenum, okay, the bleeding can happen because of the gastroduodenal artery, because this is an artery which supplies two structures. And does anyone remember? Gastroduodenal artery, what branches it give?
Right gastroepiploic artery.
Okay, good. Right gastroepiploic artery and the pancreatoduodenal artery, right? And pancreatoduodenal artery supplies the duodenum. Okay, so the bleeding will happen because of the gastroduodenal artery, right, in the duodenum. So the patient will have a epigastric pain. He will have the this hematmesis or the bleeding, vomiting, bloody vomiting, and they have unstable vitals like shock, low BP, high heart rate, right? These things. Second thing, because in case of ulcers, you're having a damage of the stem cells also. So healing will happen because of the fibrosis, and because of the fibrosis, you can have an obstruction also. Okay, very important. So because of the obstruction, you can have a vomiting with the food eating. Whenever you eat the food, you will have the vomiting, you will have the constipation, you will have a stomach distension. Okay, so a patient will have a very prolonged history of the ulcers, and now he is having this vomiting, he will having this abdominal distension, he will be having this constipation. That means it is a obstruction. Other thing, if bleeding not happens, then ulcer can cause the perforation within the GI tract, right? And whenever the perforation occur, that can lead to a free air within your abdomen. Okay, when you do the X-ray of the patient, you can even see the free air within the duodenum. Oh, sorry, within the abdomen. Okay, and this free air is present just below the diaphragm, as you can see here. This is the last part where the diaphragm must end. Okay, and you can see the air beneath this diaphragm. This is the level of the diaphragm. Okay, this is the rib. This is a level of the diaphragm, and you can see this free air within the diaphragm, right? So this is what you see with the perforation of this ulcer. Okay, so whenever the perforation occur, that can lead to the free air within the abdomen, and it will present you with this free air under the diaphragm, right? It will irritate the diaphragm. And does anyone know which nerve supplies the diaphragm?
Phrenic.
Phrenic nerve. So because of the irritation, the phrenic nerve will become activated, and it will cause the pain in the jaw. It will cause the pain in the shoulder. It will cause the pain in the arm, right? Very important. So you will have a pain in the arm, you will have a pain in the jaw, and you will have a pain in the shoulders because of this perforation, right? And you can see the free air within the abdominal cavity also. Is that okay?
Yes.
Good. So that's all about the stomach. Okay. The other two diseases which involves the stomach, first is the diabetic gastroparesis. Okay. And second is the diabetic diarrhea. Okay. So first we'll study about the diabetic gastroparesis, in which you will have a damage to what neurons?
Parasympathetic.
Parasympathetic neurons, right? And because of the parasympathetic neurons, you will lost your mobility, right? And as a result, you will have the constipation. Okay. Now, but the actual scenario in case of diabetic gastroparesis is just give me a second. See, what's going to happen in diabetic gastroparesis? It is because of the destruction of the enteric neurons. Okay. 2-3 things will be happening. First is the loss of nitric oxide releasing neurons. Okay. And because the nitric oxide is involved in the relaxation, right? It is involved in the relaxation. So what's going to happen now? Your stomach cannot be relaxed. Okay. This nitric oxide will be lost from the stomach only. So the sphincter would be absolutely normal, right? But the stomach, which should be relaxed for the accommodation of the food, the stomach is not relaxing. And as a result, it won't accommodate the food much, right? And because it is not accommodating the food, you will have something known as the early satiety. Okay, first thing. Now, second thing, you will have a delayed gastric emptying because of loss of mobility, right? You are having a delayed gastric emptying that will further promote the early satiety. Because the stomach is not accommodating the food, what's going to happen to the food? It will be regurgitate out, right? And it will present as the regurgitation and the vomiting, right? And you will also have irregular contractions in the stomach. And what cells causes the contraction in the stomach? Does anyone remember?
Kahal.
Cajal cells, yes, interstitial cells of Cajal. Because this the diabetes will also affect these cells, right? So these cells will get damaged, and because of a damage in these cells, you will have uncoordinated contractions, right? So first thing is a damage to the nitric oxide releasing neurons, and as a result, your stomach cannot accommodate the food. The food will be regurgitated out. It will cause the vomiting. It will cause a regurgitation, right? Second thing, because of the uncoordinated contraction, you will have a kind of the constipation, right? You will also have a delayed gastric emptying because of because of the uncoordinated contraction and the loss of accommodation. You will have a delayed gastric emptying. You will have an early satiety. So what are the clinical presentations? Now you can easily imagine it will be a postprandial nausea and vomiting, all right? It would be the early satiety. It would be the regurgitation of the undigested particles, right? It would be the weight loss. Is that okay?
Yeah.
And please note the sphincters are absolutely normal in case of diabetic gastroparesis. Okay, this is an important fact. Sphincters are absolutely normal. The major thing is because of loss of accommodation, because of loss of nitric oxide releasing neurons, and second thing, because of loss of Cajal cells. So 2 things: no distension of the stomach and the irregular contractions. These 2 things will causing the symptoms of the diabetic gastroparesis. Is that okay? Any doubt?
Could you please repeat what happens if nitric oxide is not being released?
See, the function of nitric oxide is to cause a relaxation of the muscles.
Yeah.
So in order to accommodate the food, the stomach need to be distended, right?
Yeah.
If the nitric oxide releasing neurons are lost, then nitric oxide won't cause the distension of the stomach, right?
Right.
So distension won't happen.
Okay.
If distension does not happen, all of the food that you're ingesting, it will be thrown out, regurgitated back.
Yeah.
So this is a symptom which is happening, the regurgitation that you see, right?
Okay. Okay. Got it. Thank you.
But note that the sphincters are absolutely normal. Okay. What you have is basically the loss of distension and the irregular contractions. These 2 things are causing the diabetic gastroparesis: the constipation, the regurgitation, the nausea, the vomiting, early satiety, okay, and the chest pain also. weight loss plus. Okay, these are the clinical presentation of the diabetic gastroparesis. Please forget this paragraph. Don't look at it. Okay, it is not the complete information. Okay, what I'm telling you is the complete one. Okay, you can write it somewhere if you want. The two causes and the clinical presentation. So what is the treatment? Treatment first would be to give the patient what drugs? Antibiotics, remember?
Yes.
What antibiotics?
Macrolides.
Macrolides. They will stimulate the motility receptors, that will promote the GI motility, right? Second are the metoclopramide, right? But you have to give the metoclopramide with a drug, which is
Domperidone.
not the domperidone. It is kind of a,
Procyclidine.
yes. Okay. No, not that. Metoclopramide should be given along with another drug to prevent the EPS. What drug? The antihistamine diphenhydramine. Okay.
Okay.
You have to give the this metoclopramide along with the antihistamine drug, which is a diphenhydramine, to prevent the extrapyramidal syndrome symptoms, right? Very important. So these two drugs will be useful for the diabetic gastroparesis, right? And yeah, that's all about it. Any doubt?
No, thank you.
Okay, so we'll take a short break again and then
Yes,
start
please.
the intestine part. Okay, we have finished with the stomach completely. Now we'll start the intestine. Okay.
Okay.
So we are done with the salivary glands first. Then we studied the esophagus completely. We have studied all the pathologies that involve your stomach. Okay, and now we are moving forward to discuss the small intestine, right? So here comes the malabsorption syndromes that involves the small intestine, right? Okay, so first one is involved. So all of these absorption syndromes, okay, they all can cause the diarrhea. First thing, if you have the malabsorption, then you can have a diarrhea, right? They will have a fat malabsorption. Every disease, they will have a fat malabsorption. So you can have a steatorrhea, right? Because of the malabsorption, you will also have a weight loss. Okay. Because of the malabsorption, you will have a weakness, right? And because of the fat malabsorption, you will also have the vitamin A, D, E, K, which are a fat soluble vitamin deficiency. Okay. And other mineral deficiencies like the calcium, like the iron, okay, and like other minerals also, right? For all of these malabsorption syndrome, the very sensitive test that you can do is the Sudan staining. Okay, Sudan staining is done for the fat. Okay, and it will check the presence of fat in the stools, right? So whenever you do the Sudan staining, and it will show the fat in the stools, that means the this malabsorption is because of all of these syndromes. Could be all of these syndromes, right? Any of them, right? So this is also whenever step one asks you about a sensitive test for the malabsorption, it would be the Sudan staining. Okay, if you come, if the Sudan staining shows the positive test, okay, that means either of this syndrome can be a cause of it. Okay, and if the step one asks you any specific test, then you have to know the specific test for every disorder, right? But first you will do the Sudan staining, then only you will do the specific test. Okay, now the first one is the celiac disease, which is a gluten sensitive enteropathy, which means it is kind of a hypersensitivity reaction against the gluten. Okay, and the gluten is found in your wheat and barley, right? Wheat and barley, they contains the gluten, right? And your body become very sensitive to the gluten, and as a result, okay, the antibodies are formed, and these antibodies includes the IgA anti-tissue transglutaminase. Transglutaminase is basically an enzyme which is involved in the absorption and the metabolism of this gluten, right? The absorption of the gluten is done by this enzyme, the transglutaminase. So IgA antibodies, which are found in the GI tract, they formed against them. So IgA anti-tissue transglutaminase antibodies are formed. Second are the anti-endomysial antibody. Okay, and third are the anti-deaminase gliadin peptide antibodies. Okay, gliadin is basically a protein in the gluten, right? Antibodies are also forming against it. Okay, so anti-deamidated gliadin peptide antibodies or anti-gliadin peptide antibodies, these are also found in the celiac disease, right? And this disorder is generally associated with the peoples which have this HLA-DQ2 and HLA-DQ8, right? So because D is involved, that means it is MHC2, not MHC1, it is MHC2 involved, right? So it is a kind of type 4 hypersensitivity reaction, you can say, because it involves the lymphocytes, the CD8 lymphocytes, the CD4 lymphocytes, okay? But it also involves the B lymphocytes, right? And that's why you're having these antibody formations, okay? So what you will see whenever you do the biopsy of a patient with the celiac disease, first thing is the erosions of the mucosa, right? The very first thing you will see is the erosions of the mucosa, right? You will see the villus atrophy, okay? Because of the inflammation, you will have a villus atrophy. If I annotate it, then normally you have these villi, right, in the duodenum. Because of the villus atrophy, all of these villi are lost, and you will have a crypt hyperplasia. So all of these villi will be like that. Okay, just like it would be seen as like you are seeing the histology of a colon, because in the colon there won't be any villi, like, right? So whenever step 1 shows you a histology of the duodenum and it is looking like a colon to you, that means it is a villus atrophy. Okay, very important. First thing, okay. Second thing, when you do the biopsy, what you will see is the CD4 cells as well as the CD8 cells. Okay, CD8 cells, they are found within the lamina propria, okay, as well as in the subepithelial regions. Very important to know the location. Okay, B lymphocytes are found within the epithelium and the subepithelium layers. Okay, and there they will secrete the IgA antibodies, right, which will be causing all of these syndromes. Second are the T lymphocytes and macrophages. They are specifically found within the lamina propria only. Okay, so two things. First is the epithelial B lymphocytes, and second is the lamina propria T lymphocytes and the macrophages. These things you will see in the biopsy of the patient for the celiac disease, right? Now, because of the involvement of the T cells, you have an increased risk of T cell lymphoma. Very important. The patient will be having a increased risk of T cell lymphoma. Okay, so intraepithelial lymphocytosis, as the FA mentioned, it is a B lymphocytes, and you have a T lymphocytes and macrophage in the lamina propria, and you will have a T cell lymphoma risk. Very important. Now, the celiac disease, it mainly involves the duodenum, right? And because you know that the iron absorption specifically happens in the duodenum. Okay, so in the celiac disease, you can have a deficiency of the iron that can lead to the iron deficiency anemia, right? And sometimes it can also involve the proximal jejunum also. And just like any other malabsorption disease, you can have a steatorrhea, you will have the diarrhea, you will have the deficiency of vitamin A, D, E, K, you will have a weight loss, weakness, right? And the thing you will do is the Sudan staining first. When the Sudan staining shows the fat, then for the specific test of the celiac disease, you can do the D-xylose test. And if you guys remember, whenever you have a damage to the breastwater epithelium, like in case of like in case of the celiac disease, you're having a villus atrophy. That means you cannot absorb the xylose. As a result, you will have a positive D-xylose test, right? And this test is very helpful in differentiating the pancreatic insufficiency with the celiac disease, because in case of pancreatic insufficiency, you're also having the malabsorption, but that malabsorption is because of loss of enzymes, not because of any structural damage, right? And the treatment will be the gluten-free diet. Now, other than the GI tract, you can also have a skin symptoms, right? And this is known as the dermatitis herpetiformis, okay, in which you have a kind of a pruritic rashes, okay, over the elbows and the knees. Okay, you will have a very pruritic rash, okay, vascular type. That's why the name herpetic, dermatitis herpetiformis, because it is a vesicular kind of rash on the elbows and the knees, and it is very much pruritic, right? And when you do the biopsy of the patient with the dermatitis herpetiformis, you will see the IgA microabscess, IgA antibody microabscess, you will see, right? So this is the extra GI involvement, and plus you are having a loss of nutrients, so you will also have a loss of bone density, right? And yeah, so that would be it. The cause is very important. Antibodies names are very important. In what individuals, like actually DQ2 to DQ8, you can see these conditions, right? What you will see on the biopsy of the patient, it is very important. What are the symptoms, the GI symptoms and the extra GI symptoms, right? And what tests you can perform. So you will study that celiac disease under these 4 headings. Okay, the cause, that includes antibody names. Okay, then the biopsy of the patient, right? The test you will perform, and the symptoms, the GI symptoms and the extra GI symptoms. Any doubt on the celiac disease?
I have one question.
Yes.
What were you saying about pancreatic insufficiency?
See, in case of pancreatic insufficiency, you're having a loss of enzymes, lipases. They won't be functional, right?
Yes.
So in that case also, like for example, say the chronic pancreatitis, in which your pancreas, your pancreas is being damaged completely, right? So you won't have any pancreatic enzyme in the GI tract, so you will have a malabsorption there also.
Yeah.
In that case, you have a normal structure of the GI tract, right? The parenchyma of the GI tract is absolutely normal. So the xylose will be absorbing normally because it do not require any enzyme.
Yeah.
So a D-xylose test would be negative, but in case of celiac disease, the D-xylose test is positive, right?
Okay. Okay. Yeah.
That's very important to note. Now, the second thing is the lactose intolerance. You guys already know about the lactose intolerance, in which you're having a deficiency of lactase enzyme. Okay, lactose is a disaccharide. It should be converted into the monosaccharide first by the lactase, so that it could, so that these monosaccharides could be absorbed. And does anyone remember the monosaccharides that form the lactose?
Glucose,
Glucose
galactose.
and galactose.
Glucose and galactose, yes. So you have 2 types of deficiency. One is a primary and one is a secondary. In case of a primary deficiency, you are just, age-related loss of this lactose happen, lactase enzyme happen. Okay, or it could be a mutation sometimes. Okay, this primary deficiency most commonly seen in the Asian populations. Okay, they will have a age-related decline in the lactase levels, or sometimes they don't even have a lactase from the birth. In these patients, if you do the biopsy of the GI tract, it would be absolutely normal, right? There won't be any damage to the GI tract. Is that okay? A normal biopsy in case of primary deficiency. Yes? Is that okay?
Yeah.
In case of a secondary deficiency, you are having a deficiency because of a damage. Because you guys know that this enzyme is found in the epithelium. So whenever you have epithelial damage, this enzyme will be lost. And as a result, you will get a secondary deficiency of lactase, which generally happens with the enteropathies, like the rotavirus infection or any bacterial or any parasitic infection like the giardiasis, for example. So whenever you have a diarrheal episode with the virus or with the bacteria, right, and the symptoms are resolved, for say you have used the drugs, you have taken a full course, but after some time, okay, along with the milk, because this diarrhea will only happen when you drink the milk, right? The patient will be starting having the diarrhea with the milk, with the milk consumption, right? And that's how you know that the patient is having a secondary lactose intolerance. Now, if you do the biopsy, you will see the damage to the villi. You will see the loss of villi, right? That is a lactose intolerance, the primary and the secondary. Is that okay up to here?
Yeah. Yeah.
Can you have a lactose deficiency in, the lactose intolerance in the celiac disease?
Yeah, because mucosal injury can lead to atrophy.
Yeah, exactly. And can you have a D-xylose test positive in secondary lactose intolerance?
Yeah.
Exactly. Okay, remember that facts. Now, if you cannot digest the lactose, okay, then this lactose will be digested by the bacteria in your GI tract. And when the bacteria feed on this lactose, they will release the hydrogen first. Okay, they will form the lactic acid with this lactase. Okay, with this lactose. So the pH will be decreased, acid will be released, H plus ion concentration in the GI tract will be increased, right? And so H plus ions will be increased, acid would be formed, right? And the osmotic pressure or I can say the osmolarity of the GI tract will be increased because lactose is osmotically active,
Yes.
right? And because it is osmotically active, it can lead to the diarrhea because it will draw the water along with it. And when it draw the water, it can lead to the diarrhea. So diarrhea only happens when you consume the milk. Is that okay?
Yeah. Okay.
And what is the treatment? Treatment is to give the patient lactase therapy, lactase enzyme replacement therapy. Okay. Give me a second. Okay, so that was all about the lactose intolerance. Any doubt in it?
I have a question.
Yes.
Can we get positive D-xylose test in primary lactose intolerance?
See, in case of primary lactose intolerance, you have an absolutely normal intestine. No damage to no damage to the intestine happen. The primary deficiencies is because of some kind of a mutation by birth, right? Or or uh, or it is because of age-related deficiency. Okay, with the age, you will have a low level of this lactase enzyme, right? So the intestine is normal, so you have a normal D-xylose test. Okay, nothing abnormal.
Okay, thank you so much.
And other test you can do for the lactose intolerance is a hydrogen breath test because you have a high this iron level in the GI tract. Okay, so you will easily diagnose this by checking the levels of hydrogen in the breath. If you have a high hydrogen in the breath, that means you have a high ions in the GI tract, which means you have a lactose intolerance. Is that okay?
Yes.
Okay. So symptoms includes abdominal pain, sometimes the diarrhea, which is osmotic type of diarrhea, right? And you will also have the abdominal distension, bloating sensation will occur to the patient, will happen to the patient. Okay. These are all the symptoms, and all of these symptoms occur only after consumption of the milk. Okay. So now comes pancreatic insufficiency. It generally happens because of a chronic pancreatitis. The cause of chronic pancreatitis, it includes a cystic fibrosis, right? And it includes the alcoholism, right? And any kind of obstruction of the cancer, like the pancreatic head cancer. If you have a cancer in the pancreatic head, then you guys know that it will that uh, it will block the ampoule of the water, and as a result, you will have a gallbladder distension, right? You will have the hyperbilirubinemia, right? You will have the pancreatic insufficiency also. So cancer, alcohol, and cystic fibrosis. These are three major important causes for the chronic pancreatitis. You will have a pancreatic insufficiency in this case because no enzyme, no pancreatic enzyme is present in the GI tract like the lipases, amylases, or the proteases. You will have a loss of fat. You will have a loss of protein. You will have a loss of polysaccharides also. Okay. And because you guys know that for the absorption of the vitamin B12, okay, you need to remove it from the R binder in the duodenum, and that is done by the pancreatic enzymes, the proteases, right? So because the proteases are not there, the R binder will be still attached with the vitamin B12, right? And as a result, the vitamin B12 can never be absorbed in the ileum. So in case of pancreatic insufficiency, specifically you also have a vitamin B12 deficiency. Is that okay?
Yeah.
And could you have a vitamin B12 deficiency in celiac disease?
No.
No. Okay, because you're having absolutely normal proteases, you're having a normal absorption of the vitamin B12. Okay, so for the malabsorption syndromes, only the pancreatic insufficiency can cause the vitamin B12 deficiency. Okay, and the bicarbonate level in the GI tract will be reduced because you know that the pancreas is responsible for the secretion of bicarbonate. Second thing, you can check for the elastasis level because elastase is a protease released by the pancreas. If this enzyme is not there, that means you have a deficiency of the pancreatic secretions. Okay. Then comes the tropical spur. Okay. In case of a tropical spur, okay, it is similar to that of celiac disease. Okay, but celiac disease is kind of an autoimmune condition that do not respond to antibiotics, right? In case of tropical spur, you have a similar findings as that of celiac spur, but this condition is responding to the antibiotics, right? And it is generally seen in all these individuals who have a recent visit to the tropics. So whenever step one give you a patient with a tropical spur, they always mention that the patient has a history of traveling. A history of traveling is must. And second thing, when you give the antibiotics, the symptoms are resolved. But in case of a celiac disease, if you even give you, even if you give the patient antibiotics, the symptoms won't resolve. Okay, and a tropical spur is specifically also affecting the jejunum, right? It will be affecting the jejunum also. Okay, and with that time, if the condition progress, it can also affect the ileum. And if you affect the ileum, and in that case, you can expect a vitamin B12 deficiency also in a very later disease. Okay, not in a very early stage, in a very later stage, you can also expect a vitamin B12 deficiency in case of tropical spur. Is that okay?
Yes.
And finally, the Whipple's disease. Whipple's disease is caused by the gram-positive bacteria, which is a Tropharema whippleyi. Okay, and if you guys remember the general microbiology lectures, then we have discussed about the pass staining in it, and we have discussed that specifically for the microbe. Okay, the pass staining is done for the Tropharema whippleyi, right?
Yes.
Because this bacteria has a polysaccharide capsule, okay, which could be detected by the pass staining. Pass staining is used for detection of polysaccharides, right? The proteins which have the saccharides in them. Okay. And can anyone remember other microorganism that we stain with the pass staining?
Cryptococcus.
Exactly. Why Cryptococcus? Because it also has a polysaccharide capsule, right? So always remember that the Cryptococcus as well as the Whipple's disease, we use the pass staining. Okay. So basically, what happens now? The macrophages will ingest this bacteria, right? And so you can easily visualize the macrophages. Okay, whenever you do the pass staining, okay, you will see this reddish stain everywhere. You can see this reddish staining. This is the Whipple's. This is the pass staining. Okay, and all of the macrophages will be ingesting this bacteria. Okay, so bacteria is intracellular organism, right? It will be present in the macrophages only. So if the step one asks you, okay, where does this stain go? It will go into the macrophages in the lamina propria, of course, because that's where all the inflammatory cells present, right? And this GI manifestations of the Whipple's disease occur at a very later stage. Initially, you will have the cardiac symptoms, joint pain, and the neurological symptoms. Okay, so first with the Whipple's disease, you will have a migratory polyarthritis, okay, or the cardiac symptoms like the chest pain could be there, right? And only in the later diseases, only in the later stages, you will have the this malabsorption disease. Okay, very important. And when you do the biopsy of the patient, you will stain them for the pass staining. The pass staining will be showing this, wherever you see the pinkish area, this everywhere, it is the polysaccharide presence, right? And which is in the macrophages. Okay, any doubt in the Whipple's disease?
No, thank you.
Okay. Now you need to know about the diabetic diarrhea. We have discussed about the diabetic gastroparesis, right? In which you have a damage of the parasympathetic neurons, right? In case of diabetic diarrhea, you are having a damage to the sympathetic neurons, and as a result, the parasympathetic system will become too much active, and it will cause the diarrhea. Now, the important thing to note that it is an osmotic type of diarrhea, right? Which means the diarrhea will also happen even in the night time when the patient is empty stomach, right? In case of a malabsorptive type of diarrhea, you will have that diarrhea only when you eat food, right? In case of celiac disease, when you eat the wheat, barley, rice, you will have the diarrhea. In case of lactose intolerance, you will have the diarrhea with the milk consumption, right? And similar, please turn off your mic. Yeah, good. Okay, so but in case of this diabetic diarrhea, because it is kind of an osmotic diarrhea, so you even have a diarrhea, sorry, not the, sorry, I'm sorry about that, not the osmotic diarrhea, but the secretory diarrhea. Okay, So it is because of a secretory diarrhea. It will also happen in the empty stomach. Okay, so a general presenting complaint would be a nighttime diarrhea when the patient is sleeping. Okay, because you sleep with the empty stomach, so the diarrhea will happen, right? So in this scenario, you will have a very increased colonic motility. You will have an increased intestinal secretions. Okay, so it will be a secretory-like diarrhea. So the patient will present you with a painless watery diarrhea. Okay, and it even persisted at the night while fasting. Labs are absolutely normal. You do the biopsy came out to be absolutely normal. Nothing is wrong, right? But the only thing that you will get is a high glucose level. So a patient with high glucose level and the diarrhea, that means it is a diabetic diarrhea. Is that okay?
Yeah.
And also note the fact that motility is more than the secretion. So if the step 1 will ask you the cause behind it, they will give you both the secretion in the option as well as the motility in the option. And if they give you both, then you need to choose a motility. Okay, because this is a major thing. Secretions are kind of a minor thing, right? Okay, then the short bowel syndrome, we have discussed it already, right? In that case, you will have the resection of the bowels so that the length of the bowel will be decreased. And if the length of the bowel will be decreased, then your food will get less time for the absorption. You will get the malabsorption, you will get the diarrhea, right? So it will present as a postprandial voluminous diarrhea, right? You will get the weight loss also. And along with that, you can also have a loss of fat as well as the vitamin B12. If you do the ileal resection, then in that case, the vitamin B12 will get less time in the ileum to get absorbed. And as a result, you will get the diarrhea. And yeah, and the deficiency of vitamin B12 that can lead to the megaloblastic anemia. Is that okay?
Yes, yes.
So that's all about the this intestine disorders, right? The malabsorption disorders, I must say, right? And yeah, just give me a second to check if there's more information on this page. That would be it. No doubt, I think.
No, thank you.
No.
Okay, now comes the inflammatory bowel diseases. Just give me a second again. Coffee? So now comes the inflammatory bowel diseases, and as the name suggests, they always include the inflammation in them. Okay, you have two categories. One is the Crohn's disease, and second is the ulcerative colitis. Now, as a name suggests, ulcerative colitis is the inflammation of the colon, right? Not the ileum. And because it has ulcerative colitis, so it is a ulcers in the colon, I must say, right? So whenever you heard the word ulcerative colitis, that means it is a ulcers in the colon along with the inflammation, right? And in the Crohn's disease, it involves, any part of your GI tract, from esophagus to the rectum, or not the rectum, but the colon, esophagus to colon. Any part of your GI tract could be involved with the Crohn's disease, right? Except the rectum part. Okay. And the most commonly affected part in the Crohn's disease is the ileum. Okay, so whenever you have a Crohn's disease, ileum is almost every time affected. Okay, and that's why you have to do the ileal resection. That's why you get the vitamin B12 deficiency in the Crohn's disease. So in the Crohn's disease, it is basically the autoimmune inflammation of the GI tract, in the intestine, in the colon, anywhere, but most often in the ileum. In case of ulcerative colitis, it is an ulcerative inflammation that involves only the colon part. Okay, and it is kind of an ascending type of inflammation. What does it mean? If this is your colon, then the inflammation first affects your rectum. Okay, it will first affect the rectum, then it will go in the ascending way, in the ascending part, and then it will affect the sigmoid colon. Okay, then it will affect the ascending colon, then it will affect the transverse colon. Okay, so it is a kind of ascending inflammation, right? So you can say easily that rectum is always involved in case of ulcerative colitis. Is that okay?
Yes.
The Crohn's disease contains skip lesions, which means some areas would be present with the inflammation and some areas are normal. Then you come some areas which are again inflamed, then again some areas with the normal tissue, normal parenchyma. In case of ulcerative colitis, you have a continuous inflammation. Okay, first the inflammation will be present to the rectum, then it will ascend upward involving the sigmoid colon, then the ascending colon, then the other colon, right? So the inflammation will always be continuous in case of ulcerative colitis. In case of Crohn's disease, it would be the it would be skip lesions present, and the ileum is always involved, right? On the gross examination, how will you do the gross examination of this Crohn's disease and the ulcerative colitis?
Colonoscopy and endoscopy.
Exactly. You will do the endoscopy, you will do the X-ray of the patient, right? These things you can do to check for the gross morphology. So when you do the endoscopy, okay, what you will see is the transmural. First thing, when you do the endoscopy, you will see the erythematous areas. Okay, you will see the erythematous areas in your GI tract. Okay, some areas will be erythematous, which means inflamed, and some areas are normal. Then you again encounter some areas with the inflammation, then again some areas which are normal, right? Just give me a second again. What other things you can also see along with the inflammation? The first thing is the fistula, because you guys know that in case of Crohn's disease, the inflammation is transmural, which means it involves every layer of the GI wall, right? So it can so adjacent, if if the inflammation happened between two adjacent intestinal loops, then it can lead to the formation of fistula, which you can easily see in the endoscopy, right? Third thing would be the healing by the fibrosis, because it is a transmural inflammation. The stem cells are lost, and now when the healing occur, it will always involve the fibrosis. Because of the fibrosis, stricture formation can happen that can cause the obstruction, which you can see in the endoscopy also. Okay, so in the endoscopy, the first thing you will see is the fistula formation. Erythematous areas are there with some skip lesions, right? You can see the stricture formation. You can see the bowel wall thickening, right? And the other thing is the cobblestone mucosa. Other thing is the cobblestone mucosa. See, some areas are basically inflamed, okay, and these areas will become very much edematous, okay, and swelling would be there. So you will see a very raised lesion in that area, and the areas which are normal, okay, you will see a depression in this area. So areas normal, then depression, normal and depression. So this will appear as like a cobblestone mucosa. Are you getting me?
Yeah.
If I annotate it, then within the when you do the endoscopy, you will see some areas like these are the raised lesions like that. Okay, then an area with a small lining, which is kind of depression, seen like depression. Then again area which is raised. Okay, then again the areas with the depression. So this kind of thing you will see on the endoscopy, right? This is a cobblestone mucosa. And the areas which are raised, these are the areas where the inflammation is present. The areas where the depression is present, these are the normal mucosa. Okay. So what are the endoscopic findings or the gross findings? First thing is the inflammation. Okay, it would be a transmural inflammation, right? The cobblestone mucosa you will see. Okay, you will see the fistula formation, right? You will see the fibrosis, the stricture formation you will see. Okay, and the other important thing is the creeping fat. Now, because of the fibrosis, because of the healing, you will have the myofibroblast that will cause the fibrosis and the healing process. And the function of the myofibroblast is to cause the contraction of the wound, right? And while contracting the wound, they can also contract the fat around the GI tract, right? And that can cause the creeping fat formation. Okay, so the creeping fat, bowel wall thickness, cobblestone mucosa, fistulas, and stricture formation. These are things you will see on the gross morphology. Is that okay?
Yeah.
Okay, good. Second thing is the microscopic. Yeah. Second thing is the microscopic examination. Okay. Once you do the endoscopy, you know that the inflammation is there, that the patient is having a Crohn's disease. To further ensure, you need to do the biopsy, right? You will take the samples of the inflamed area, and what you will see on the biopsy is the non-caseating granulomas. Okay, it is a granulomatous inflammation, and that means because the inflammation is involved in the granulomas, it is a type 4 hypersensitivity. Can I say that?
Yes.
Because it involves only the Th1 cells. Because CD4 helper cells, they will activate the macrophages. Macrophages get activated and they will form the granuloma. And it is a non-caseating type because no microbe is involved. It is a purely autoimmune condition. Okay, so the gross morphology is done, the microscopic morphology is done. Now the complications, we have discussed that already. You will have the fistulas. Now the fistulas can form between the GI loops, between the two intestinal loops. Okay, it is known as the enteroenteric fistula. Okay, when the fistula happen between two loops of the bowel, it will be known as the enteroenteric fistula. The fistula can happen between the bowel wall and other organs also. Okay, let's say the vagina, or it could be a bladder. Okay, so what you will see is the air in the urine. Okay, because of the fistula formation between the GI tract and the bladder, you will see the air in the urine. Okay, or you will see some sometimes a stool in the urine can also be seen, right? Same thing with the vagina. Okay, if you have the bowel wall and the other organ fistula, okay, the fistula can also form between the bowel wall and the skin, right? And what you will see is the bowel contents being drained from the skin. If you have a fistula formation between the skin and the bowel, then you will see the bowel contents being drained from the skin. Is that okay?
Yeah.
And because the GI tract, it contains many bacteria. So if a fistula is formed between the bladder and the GI tract, then all the bacteria can leak into the bladder and that can cause the UTI. So the patient will also present you with the recurrent UTIs, right?
Yeah.
So these are the complications for the fistula. Now comes the stricture formation. If you have the stricture formation, which is because of the healing by fibrosis, then you can have an obstruction in the GI passage. What you will see is the constipation, abdominal distension, nausea, vomiting with the eating, right? Yes.
Could you please repeat?
Because of the stricture formation, which is the healing by fibrosis, you're obstructing the GI lumen. Okay, and whenever you eat something, it will get stuck in the GI tract. It will cause a constipation, abdominal distension because the food is being accumulated before the obstruction, right? It will cause a nausea and vomiting. So these are complications with the stricture formation. Now, if a fistula is formed between the skin and the bowel loop, in that case, all of the these anaerobes which are present in the GI tract, and can anyone name the most abundant anaerobe in the GI tract?
Bacterioids.
Coli?
Bacterioids. E. coli is the second or I think third one, not the most common. Okay, but the most common one is the bacteroid species. Okay, so they will be present in the skin now. Okay, and there they can cause the skin abscess also, right?
Yeah.
Is that okay? And you can also have, because you're having a damage with your wall, these bacteria can also leak within the walls of the GI tract, and there they can cause the abscess. Is that okay? Walls with the abscess within the walls of the GI tract, you can see easily, right? Other complications, because you guys know you are having a malabsorption, so you will be having a deficiency of vitamin A, D, E, K, right? And because this disease almost always involves the ileum, okay, so because of the inflammation of the ileum, you will be having a deficiency of vitamin B12 that can cause the megaloblastic anemia. Because you're having a fat deficiency, okay, you're having a fat malabsorption, all of the calcium will bind to the fat, and as a result, the oxalate will be absorbed, and that can lead to the oxalate stone formations, right?
Yes.
And because of the rupture of the intestine, all of the bacteria can leak into the peritoneum, right?
Yeah.
And whenever the bacteria reach to the peritoneum, they can cause a peritonitis. Yes.
Yes.
And the most common, how will you tell that a patient is having a peritonitis or not? You have a patient who is having abdominal pain because of the Crohn's disease. Okay, and now you want to make sure that the patient is not having any peritonitis. How will you do that? What test will you do? What
Or-
examination?
Fever, abdominal distension, and we'll do the peritoneal tap. We'll do
See, the
poly-
fever will be
Abdominal
present.
guarding will be there.
Yeah,
Or-
exactly. The guarding is
Guarding
very important. Guarding is very important. Whenever you palpate the patient's abdomen and you release it, if the pain is there, if the severe pain is there, that means the patient is having a peritonitis. If the pain is not there, that means the patient still have an intact GI tract. All the fistulas can form, anything can happen, but the peritoneum is still normal. So this is a test you will always do to the patient with a Crohn's disease to make sure that the patient is not having any peritonitis. Is that okay?
I did
Yes.
not get this. In peritonitis, we'll get guarding or rebound tenderness.
Both things are there.
Both of
Which
them,
is-
rebound
Which
tenderness
one
and
is
guarding.
more specific between
See,
two?
in case of appendicitis, why you're having a guarding and a rebound tenderness? It is because of inflammation of appendix. Yes?
Yeah.
No. It is not because of inflammation of appendix. It is because of the peritonitis associated with the appendicitis. You're having this pain. Okay.
Okay.
So
Okay.
that so in any case, in any inflammation of the GI tract, if the inflammation involves the peritoneum, then the patient can have a both guarding as well as a rebound tenderness. Okay. Both things are there always.
Thank you.
Okay. So we're talking about the complications. So stones we have discussed. Okay. And what about the bilirubin levels? What's going to happen to it?
Should decrease cause of decreased recirculation.
Yeah, exactly.
Absorption.
The recirculation will be decreased, right? And that will further promote the stone formation because the bile salts are getting lost, right? So you will further have the stone formations, right? And yeah, I think we have covered every complication of it. Yeah, other thing, you can also have a vitamin K deficiency. Okay, with the Crohn's disease, you can also have a vitamin K deficiency, and the vitamin K deficiency can lead to the bleeding complications, right? You will have a nose bleeding, you will have a GI tract bleeding, you will have a very improper kind of wound healing, you will have a hamartosis, you will have a brain hemorrhage because vitamin K is involved in the clotting, right? So you will have a deep tissue bleedings, right? Like the hamartosis and the and the brain hemorrhage. The patient can also have that, right? And because this Crohn's disease is a chronic inflammation, right? The patient can also have a anemia of chronic disease. Is that okay?
Yes.
And so these are
Pneumaturia is
yeah,
air in urine. Pneumaturia.
yes, air in the urine.
Okay. And it's due to the connection between the bowel
Yeah.
and the bladder.
Yes, exactly. And sometimes when the bowel rupture, you can also have a free air in the abdomen. And when the free air is present, you can also have irritation to the diaphragm that can cause the the chest pain and this the jaw pain, shoulder pain, and the arm pain. Okay, and so these are all about the GI manifestations, right? You can also have extra GI manifestations, right? And that includes the seronegative spondyloarthropathies, which are the ankylosing spondylitis, right? The peripheral arthritis. Is that okay? You will study that later again in the MSK. Okay, ankylosing spondylitis, peripheral arthritis that you will see in the Crohn's disease. Okay, the constitutional symptoms because it is an inflammatory disorder, so you will have a fever, right? A mild fever would be there along with the weight loss, and of course the malabsorption is there. So whenever you encounter a patient with a prolonged history of fever and the diarrhea, okay, prolonged history, a very chronic history of fever, abdominal pain, and diarrhea. If you encounter three things only, you can say that a patient is having a Crohn's disease or ulcerative colitis. If the bloody diarrhea is there, okay, then both the Crohn's disease as well as the ulcerative colitis can happen. Okay, if it is a non-bloody type of diarrhea, then it could be due to the Crohn's disease only. Because whenever you have a ulcerative colitis, you will always have a bloody diarrhea. Okay. Yes. So that's
What
everything
are these
about
three things? Abdominal pain, diarrhea. What else?
abdominal pain would be there, fever would be there because it is inflammation, weight loss would be there. Okay, diarrhea would be there, sometimes bloody, sometimes normal in case of Crohn's disease, but always bloody, mostly in case of ulcerative colitis. Okay. Other manifestations can include the skin rash, okay, which is like the erythema nodosum. Please note all the causes of the erythema nodosum. Okay, we will discuss them at the end. Okay. So the rash, the erythema nodosum would be there. Okay. Other inflammations in other areas can also happen. Like in case of eye, you can get the eye infection like the uveitis. Okay, you can also get the oral ulcers because you guys know that this Crohn's disease can involve any part or any part of your GI tract, right? So ulcers in the oral cavity can also happen. Arthritis, we have discussed like the seronegative spondyloarthropathies would be there, right? And yeah, that's all. The stones would be there, gallstones would be there, kidney stones would be there, right? Yeah. So any doubts so far about the Crohn's disease?
No, thank you.
So all of the complications are because of one thing, which is the transmural inflammation, right? And healing. And the other test that you can do is
My
to check
question is,
Yeah.
abdominal pain and diarrhea can also be present in IBS. So fever
Yes.
is the thing that is going to
Yeah,
differentiate
exactly.
between.
Yeah,
Okay.
see, the name always would tell itself. See, in case of IBS, you are having what? The irritable bowel syndrome. It is not because of any inflammation. But the inflammatory bowel diseases are because of inflammation. And whenever you have an inflammation in the body, you will have a fever, right?
Oh, all right.
So that's why in case of IBS, in case of IBD, you're having fever. In case of IBS, you're not having any fever, right? And the other test you can do is the anti-Saccharomyces cerevisiae antibodies, ASCA. Okay, generally these patients are also positive for these antibodies mostly. Treatment, it includes all the drugs which inhibit the granuloma formations. That includes the TNF alpha inhibitors because the TNF alpha is responsible for the maintenance of the granuloma. Okay. Other thing you can do is the glucocorticoids, right? And there is one more drug that you can give to the patient, the antibodies. Remember the name of the antibodies? Anti-TNF alpha antibodies. Anyone know the name?
Infliximab.
Adalimumab and infliximab. Okay, these are the anti-TNF alpha antibodies, right? And you also have a receptor, a decoy receptor for the TNF alpha. Anyone remember the name?
Etanercept.
Yeah, exactly. So these are the treatments for the Crohn's disease. Okay, and once all of the treatments are failed, you need to do the bowel resection, in which you remove the ileum or other part of the inflamed bowel, right? So yeah, that's about the treatment. Yeah, that's all about the Crohn's disease. Any doubt?
No, thank you.
Okay, now comes the ulcerative colitis. As the name suggests, ulcers in the colon, okay, which causes the inflammation, of course. Continuous inflammation, we have discussed, always involves a rectum. It is always an ascending type. Rectum involved first, then other parts of the colon. It will be specifically limited to the colons only, no intestinal involvement. It will always cause a bloody diarrhea, okay. And the ulcers, it would be limited to the mucosa and submucosa. It is not a transmural inflammation, okay, but only involves the mucosa and the submucosa. Okay, you will have in this scenario, in this disease, you will have a loss of normal hostrations. Okay, and because of this loss of hostra, you can have a lead pipe appearance on the imaging. See, generally when you look for the colon, it will be seen like this, right? And these are known as the hostrations, right? Like that. In case of Crohn's, in case of ulcerative colitis, all of these hostrations are lost, and what you will see is this type of appearance of the colon, and this is known as a lead pipe appearance. You give the patient barium swallow. Okay, you will check for the dye, where the dye is goes. Then you will do the X-ray. On the X-ray, you will see this type of colon. It is known as the lead pipe appearance of the colon, right?
Yeah.
Okay. And so on the microscopy, you will see the first the ulcers, and then you will see the crypt abscess. Please remember, the crypt hyperplasia is seen in the celiac disease, and the crypt abscess is seen in the ulcerative colitis. Do not get confused between the two, okay? And there won't be any galloma formation happen, and it is Th2 mediated, not the Th1. It is Th2 mediated, right? Then comes the complications. Complications, first you can have a fulminant colitis, okay, which is kind of very severe type. You will have a toxic megacolon. Toxic megacolon happens whenever the colon becomes very dilated. Because of increase in the interluminal pressure, the colon will become very dilated, right? And when the colon become dilated, it is it has a very high risk of being ruptured, right? And when it ruptured, it can lead to the peritonitis. So again, in case of the ulcerative colitis, you always need to check for the patient's guarding and the rebound tenderness. If it is there, that means the colon has been ruptured, okay? And that means the patient is now having the peritonitis. So it is a feared complication of the ulcerative colitis. Generally happens with the patient having a prolonged history of this ulcerative colitis, or the patients who stop taking the medications, right? Generally happen to those patients, their colon becomes so much dilated that it can rupture sometimes, okay? And how will you check for the toxic megacolon? The test.
X-ray abdomen. X-ray abdomen.
Okay. Okay. So whenever you see the patient with the abdominal distension, then only you will do the test. Now, what test would you do? Apart from the examination, you have checked for the abdominal distension. Now what you will do?
Barium enema.
You cannot do the barium enema, because if you inject any dye or anything, then it will further increase the pressure, right? And it can cause the rupture of the colon. So these things are contraindicated. Now, other test.
X-ray abdomen.
A plain X-ray of the abdomen. A plain X-ray of the abdomen is enough. It will show you the dilated loops of the colon, okay? And that's how you know the patient is having this toxic megacolon. Is that okay? See the fulminant hepatitis, which is kind of a very severe type, the most severe one. Okay, similarly, it is a fulminant colitis, a severe form of the normal colitis, okay?
Okay, thank you.
And there won't be any stricture formation, there won't be any fistula formation. Why no structure formation occur?
Transmural inflammation is not there.
Right, so stem cells are still preserved, and what you will get is a normal regeneration, not just a healing, but a regeneration, right? And you will get a bloody diarrhea, of course. And for the antibodies, you need to check for the P-ANCA antibodies, okay? And one of the associated complication is the primary sclerosing cholangitis. Very important. Step 1 will give you a patient with a history of primary sclerosing cholangitis, like the itching, like the high bilirubin levels and other things. And they will ask you what other things you need to check in this patient. Okay, so you need to check the patient for the ulcerative colitis also, right? Again, very important thing. And sure, I think that would be all about ulcerative colitis. So it would be a patient with a history of fever, abdominal pain. Okay, sometimes they could present you with abdominal distension, which means the toxic megacolon can be happening. Blood diarrhea would be there, fever would be there. Okay, and please note the age of the patient is very important for diagnosing these conditions. The patient must be a young adult before the age of 40. Generally happen between the 20 to the 40 years of age, and patient having some kind of intermittent symptoms. Okay, the patient will get a flare of these symptoms. They will get the fever, diarrhea, weight loss, fatigue. Okay, and these things comes for in and these symptoms will come in the episodes. Okay, for like a month or 2 months or 3 months. Then the resolution will occur. Asymptomatic phase is started. Then again, after 6 or 7 months later, the patient again develop the diarrhea for 2-3 months. Then again normal, then again diarrhea. So whenever you see this kind of a history of the patient, the intermittent type of diarrhea in a very young adult, that means it could be the Crohn's disease or it could be the ulcerative colitis. Versus when you see an old age patient with the diarrhea and fever, okay, it could be a case of diverticulitis. Okay, so in old age patients, if you are seeing a patient with a history of diarrhea, fever, weight loss, fatigue, It could be due to the diverticulitis in young patient in step 1. I'm talking about in step 1 in young patient, it will always be the inflammatory bowel disease. Is that okay?
Yeah.
Okay, don't forget that. So that's everything about the Crohn's disease and the ulcerative colitis. Any doubt so far?
I have a question.
Yes.
How does pseudo polyps arises in ulcerative colitis?
Yeah,
Like
yeah,
mechanism?
yeah. I forgot about that. Sorry. For the pseudopolyps, see, whenever you have the regeneration, okay, in case of the ulcerative colitis, whenever you have the regeneration, there will be the overgrowth of the regenerating mucosa. Now, because of this overgrowth, you can have a polyp formation. Okay, and these polyps are known as the pseudopolyps because they are because these are not the true polyps, but because of the hyperplasia during the regeneration process. So when you do the endoscopy, you can see the polyps in the colon. Okay, and you can and these polyps can make you think like the cancer maybe sometimes, right? So but once you do the biopsy, you can easily tell this that this patient is not having any cancer but a normal regeneration of the mucosa, right? So it is because of the overgrowth of the mucosa that can lead to the polyp formation.
Okay,
Okay.
thank you so much. Thank you.
And these patients, the patients with the Crohn's disease and the ulcerative colitis, they are at an increased risk of developing the adenocarcinoma of the colon or the intestine. Okay, they will develop the carcinoma at a very early age than the normal patient. Normally, you see the colon cancer, after 50 years of age, right? But in case of this Crohn's disease and the ulcerative colitis, this cancer can happen at a very early stages. Okay, and so what are the features of this cancer? Steven will ask you, what is the difference between a normal colon cancer and the cancer because of this ulcerative colitis or the Crohn's disease? See, first of all, the age. Okay, the age is very much younger in case of the the IBS and the normal sporadic one. Okay, in case of origin of the dysplasia, okay, in case of a sporadic cancer, sporadic colon cancer, it will be the polyploid lesion. Okay, in case of this ulcerative colitis or the Crohn's disease, it is because of a flat lesion. There won't be any polyp present. Okay, a flat lesion would be there and it will become the cancerous. In case of the colon cancer, normal sporadic one, there would be a polyp present which can ultimately progress to the cancer. If you guys remember, the phase which is known as a process completely for the maturation of the cancer, right? The adenoma carcinoma sequence, remember?
Yeah.
It generally happen in the sporadic causes of the cancer or of the colon cancer, right? But not in case of colitis associated cancer. For the tumor, for the location, the proximal colon is more involved than the distal colon. But in case of a sporadic colon cancer, the distal colon is more involved than the proximal colon. Okay, and the tumor is generally multifocal in the origin because the multiple locations are there where the tumor can arise. In case of sporadic one, a singular lesion will be there which can form the cancer later on and multiple areas. For the histology, you will see the mucinous cells, okay, or sometimes even the signet ring cells can seen in case of colitis associated cancers. Okay, and all of these cells are poorly differentiated because of a high you can say high anaplasia would be there, right? And that can lead to the signet ring cells also. In case of sporadic cancer, you can see the columnar cells, which are very well differentiated, right? And the mutation is very important. In case of a sporadic one, the first mutation would be in the APC gene, right? And then you have a KRAS, and then you have a TP53 mutation, right? But in case of a colitis associated cancer, you first have a early P53 mutation, and finally, in the very late phase, you will have the APC mutation. Okay.
Okay.
Step one can ask you these differences. Remember, the mutation is kind of very opposite in case of colitis associated. Okay, and the normal one, which is a APC, then KRAS and P53 in case of the colitis, in case of a sporadic one. Multifocal lesions in case of the colitis associated. Singular lesion in case of a normal sporadic type. Age is very important. Location is very important. Distal and proximal, right? Whether it is singular, multifocal, it is important, right? Mutations are important. These 4-5 points for the difference. Any doubt?
I have one question.
Yes.
Where, do we find any serpiginous ulcers in any of the two diseases?
Does we find any?
Serpiginous ulcers, like snake-shaped ulcers on growths.
That I'm not sure about because I didn't study that. I never read about it. Serpinous ulcers.
I think we find it in Crohn's disease.
Okay. And where have you studied this?
I have studied it in UWorld.
Okay,
I
so
have
maybe you can
annotated it
find.
in my FA.
Okay, so maybe you can find it there. You can write it down, but it wasn't in my FA. I've never studied about it, so not sure. Okay.
Okay. Thank you.
I have a question to ask. Do
Cheers.
we need to remember the association of smoking in IBD? Like it is in one disease, it increases the risk, and in other disease, it decreases the risk. It is quite confusing to
Yeah,
remember
it
the
is. But
association.
I've never encountered any fact over that, so you can just skip it if you want. But just for the knowledge purpose, you can see, you can write it down, or you can remember it. Okay. It's not useful that much. Okay. So if you want, you can
Okay, thank you.
remember.
Yeah, thank you so much.
Okay, so any more doubt on the Crohn's disease or the ulcerative colitis?
No, thank you.
So just know the location, the cause, what you will see on the gross finding, what you will see on the microscopy in both the diseases, what are the complications, because that is the most important thing. The extra GI complications are important, like the skin rash and all of these things. And then finally, the treatment is important, right? Organize the headings first and then study the diseases. It would be very easy then, right?
Yeah.
Okay, so I think we should wind up here for now. Okay.
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 Thank you.
Thank you.
Thank you so much.
Thank you so
Thank
much.
you.
Thank you.
Can you please share